of the public that are joining us today. We have got apologies this morning from Lisa Harwood, who's the interim non-executive member for the ICB, from Paul Johnson, who's the Chief Medical Officer for the Integrated Care Board, and Matt Prosser, who's the Chief Executive for Dorset Council. We have a number of people in attendance today, including Louise Bate, who's the Manager for Health Watch Dorset. Hi, Louise, I can see you on the screen. And we have various people coming along to join us for different bits of the agenda items. So rather than me reading out the names now, I would suggest that when we get to those agenda items, the person that's leading on that can do the introductions. And a welcome also to Rachel Pearce, who's here for... sorry, could everybody go on mute? Because I'm getting some feedback, although it might be in the room, obviously. So, but Rachel Pearce is here as the Southwest Region link for us. So, Rachel, do you want to say a quick hello to everybody?
Yes, hello to everybody. Just beginning to get to know the system, and I'll be working more closely with the system going forward. So delighted to meet everybody today and here sit in the board meeting. Thank you.
Thank you very much, Rachel. And then we've also got for the public, I don't know if they're on the line yet, but we're expecting Tracy Dolbear, who's Secretary, and Marcus Frith, who's the Chair of the Dorset Kidney Patients Association. We're also expecting William Johnson, who's the Service Development Executive for CHS Healthcare, Stuart Kemp, who's the Regional Market Access Manager for Gilead Healthcare Company, and Thomas Vellender, who's Head of Strategic Relationships, Healthcare Business Solutions. So welcome all. Do we have any declarations of interest? I shall take that as no. One to note for me that when we get to item 4.1, I noticed that there is reference in there to University of Southampton, and just as a reminder, I sit on the council of the University of Southampton. Okay, let's work through then. So we'll start with the minutes from the last meeting. And as usual, I will turn the pages. So if there are any corrections or clarifications for the minutes, please indicate as I go through, starting with page 1, page 2, page 3, page 4, 5, 10 and 11. So we'll take those as an accurate record of the last meeting. All of the items have been completed, so I won't focus on that unless it wants to pick anything up. So in that case, can we then go to the staff story? And Dawn, I believe you are going to introduce this today.
Thank you, Jenny. Good morning, everyone. So I'm Dawn Harvey, the Chief People Officer. Today's staff story features Freedom to Speak Up Guardians from NHS Partners. And the reason for bringing this, it builds on last month's board development safeguarding session, and it also coincides with October, that we've just come to the end of, as National Guardian Freedom to Speak Up Month. It's also timely as we have confirmation of the Thirlwall inquiry set up to examine events at the Countess of Chester Hospital and the implications following the recent trial. While the Freedom to Speak Up Guardians featured in the video are NHS staff, cultures of speaking out safety feature heavily across all of our partners, across all of the system. So you'll see the Guardians on the video share their views on the importance of the role and the conditions that are important for a culture of speaking out safely. This it includes being willing to hear, to listen, to be open, to receive concerns, and transparent communication. And then following the video, I invite discussion on the themes and for the board to consider its role in continuing to support and advocate for speaking out safely across our system. Thank you, and QVT.
So my name is Alan Young, and I'm the Freedom to Speak Up Guardian for NHS Dorset alongside my colleague Charlotte Pascoe. The role is available for everybody in NHS Dorset to come and talk to us or speak up around anything that they believe is worth challenging. NHS Dorset should be a place where you feel comfortable. It should be a place where you're able to bring your voice to, and it should be a place where you're heard. If we are not heard and we're not listened to, then I feel like it's probably going to be to the detriment of not just to us and our teams, but to everyone really.
In 2022, so in the last 12 months at UHD, we've had nearly 300 concerns raised with the Freedom to Speak Up team. So we have a chatty organisation, but as I've said and I've inferred, speaking up is everyone's business. So you know, it has to happen on a daily basis.
So I get a lot of conversations where people say, I love my job, but, and the but isn't usually a patient safety aspect. That will tend to go through the risk management route. It's usually there's a conflict of interest. I've got a relationship that's not working with this member of staff. Quite often it can be their line manager. So I really urge line managers just to be compassionate, be fair, be consistent in their management, carry out role modelling behaviour so that people can learn from you, that really reflects us as a whole, and just uphold our trust values.
So what we do know with our data, so I talked about the 300 staff that have come and spoken to us in the last 12 months. We know that they come to the Freedom to Speak Up route because around about 40% of them say, actually, my line manager is either the issue or they know about the issue, but it's just not been addressed. And that brings in those national barriers that we see at UHD as well, that fear of reprisal, which is why they're not going to their line manager, or the futility beside it, which is actually what's the point, nothing gets changed. So we very much, those national sort of pictures are being played out here at UHD. So what I do is I go and speak to the board, because we need our board to role model what we want as speaking up. And then we also go and speak to our line managers and ensure that they have the skills to listen to concerns. The complexity of any concern needs time, it needs compassion, and it needs a genuine understanding of taking something forward. And then what we do is then we talk at the staff level to encourage them that actually we want people to speak up, and if you can't speak up in the route that we would you know, that is either your line manager or so on, then actually remembering that Freedom to Speak Up exists.
I'm new to the role, so I've been here since January, and I'm just trying to explore lots of different outlets. So I've gone a bit old school. We've got an anonymous post box now, which is available, because sometimes I've had staff that email me and say, can I be anonymous please? And then they sign off with all their details. So I'm like, I can't unsee this. So we've gone a bit old school. So we've got an anonymous post box, which only I have access to. Just making as many routes as possible. The digital team are working on a sort of button that you can click on StaffNet to report a concern. You can go through the risk management route if you want to speak up. We're trying to make it as easy as possible, so it could be over email, face-to-face, on Teams, whatever works for you. So we're just trying to adopt and have as many avenues to speak up as possible. We always encourage our staff to speak to their line manager in the first instance if that's appropriate. That's a big concern that we have, is detriment following speaking up or detriment as a result of speaking up, so any repercussions from speaking up. We've got a really sort of energetic, enthusiastic, culture-driven exec board, so I'm really pleased to work alongside those to make sure that we try and instill that there will be no repercussions to speaking up. I can't guarantee that, but obviously we do our best and we try and make the process as gentle as possible. If they want to remain confidential, anonymous, they can do that, but we just let's deal with the molehills and not make them into mountains. Nip things in the bud when we can so that things don't escalate. It's much more easier to manage if you use that sort of way of working.
Speaking up through the Freedom to Speak Up Guardians is confidential, and it's really important if you have concerns around line management, or you can have concerns about something that's happening potentially to another member of staff, that you do have that voice, because otherwise things won't change, and we really need to make sure that actually things do happen and action is taken where concerns are raised. It's really important that we have a Freedom to Speak Up Guardian at the ICB. It's important that staff are able to raise any concerns that they have, whether that's the way in which they're being treated, or whether it's new ideas. And Freedom to Speak Up is a great confidential way of them doing that, and the organisation learning where things aren't going wrong and putting mitigations in place to make sure it doesn't happen again.
We all need to look at our own behaviour and how that impacts other people, and we need to develop a culture and embed that in our organisation. And it's key to remember that we as individuals make the organisation, we are the organisation. So if you reflect on a situation where you've been maybe a bit out of character, it's not too late to go back and apologise and adjust the culture, and we all need to be doing that.
I sort of say Freedom to Speak Up is like car insurance. You know it exists, but you only really need to look at the details when something's troubling you. And that's what we're there. We are a critical, impartial friend for you. So if you have a concern and you want to talk it through confidentially, then Freedom to Speak Up is here for you.
If you want to raise a concern, however small or however embarrassed you are about it, please do it. It's really important for us to learn from that. And all of the things that you raise through Freedom to Speak Up Guardians are completely confidential.
Thank you, Dawn. Did you want to say anything else before we get into discussions?
Just to reiterate, Jenny, that whilst it's the Freedom to Speak Up Guardians from NHS partners that were part of that video, that we know that all of our partners around the system have their own ways of speaking out. And we have Charlotte Pascoe, I believe, joined us on screen, who featured in the video, if anybody would like to ask Charlotte a question as well. Thanks, Jenny.
Thank you very much. Okay, I can see Charlotte now. Great. So, John, you are our Freedom to Speak Up champion on non-executive champions, so yeah, probably appropriate for you to come in first.
Yeah, well, and I was going to say exactly that. First of all, thank you to the team, and thank you, Dawn, for bringing this. Hello again, Charlotte. One of the things that I really wanted to reinforce, I think this really matters for us. If I go back to the 11th of October, actually, as part of our CQC pilot, we brought together everybody who's involved in whistleblowing and Freedom to Speak Up right across the system, from the NHS organisations, from the providers, of course, but also local government. And we were really having a conversation about why this matters. And it was really great to hear the alignment, actually, across a set of individual organisations. But I think for me, what really came out from that video is the criticality of listening up. It is so important, isn't it, to create a mechanism where people feel heard. They feel heard in a safe way. Sometimes, of course, the right place to go with any concern is to go into one's team, to go into one's organisation. But sometimes we need to have another channel that allows people to be heard, and then to know that we will take action when there is something that is happening. And I think to hear the passion and commitment about, you know, individuals who are carrying out that Freedom to Speak Up role, it was great to hear that. One of the things I do think about is how do we get this agenda right across our system and continue to, you know, hear where are the areas where we're hearing matters, but also where are we not hearing things. are there parts of our organisation where there is no voice coming through? And actually, that's the idea that I also wanted to share. I think we need to listen up, but also be curious about where we're not hearing anything as well. This is key for our teams. And thank you, Charlotte, Alan, and all of our Speak Up champions across the piece. Really great to hear that. I might come in at the end again later on, but I just wanted to make that introduction.
That's fine. Thank you very much, John. I've got Patricia and then Rhiannon.
Morning, everyone. I was build on what John said. This is really important. It's not just important to the ICB, it's important to the system and the culture that we're trying to create where people feel safe, psychologically safe, which means that they can raise any issue of concern at work and they will be listened to. And it's important that, you know, colleagues right across the organisation understand that when individuals and teams raise issues, we should be listening to understand, not listening to defend ourselves or the organisation, and then make sure that we're giving people confidence through the feedback loop that where action is required, the appropriate action has been taken in order to make sure that whatever issue they've got gets resolved and that they feel safe at work to raise any concerns, and not just concerns. People should be happy to raise any issue that they want to talk about, particularly around improvement, and know that they'll be listened to.
Thank you, Patricia. I'm going to take Rhiannon, and then the disadvantage I have of being on the screen is I can't really see if anybody's got their hands up in the room. So I'll come to the room and then go to Debbie afterwards. So Rhiannon.
Oh, thank you. As others have said, really massively important for that sense of safety, psychological safety, well-being. I mean, everybody wants or should feel that they come to work and have that sense of joy in work. Patricia made one of the points I wanted to just really focus on, I guess, is that the importance of closing the loop. So if somebody's taken that brave step to raise something, it is really important that they get that feedback, isn't it, in terms of what's happened as a result of that information they've shared. So I guess, do we have a sense of how well that's going? Because I guess some things are more thorny than other things to resolve. It was just one of the speakers on the clip made reference to patient safety things going another route. So there was a question for me about that triangulation, I guess, in terms of seeing that feedback in the round, in terms of any themes that may be rising that we need to put more effort and resource behind. And I think the other bit for me as well, and it speaks a little bit to the point John made about reach, so the voices we hear less from. So do we gather any information such as colleagues with protected characteristics who maybe there may be a disproportionate sense of feeling confident to raise issues. So it was just those couple of things, but it's great, Charlotte, to have heard the video and to you know, just such an important topic, really.
Am I able just
Charlotte or Tom, do you want to come back on those first before I go to the room, and then Debbie and Matthew?
Yeah, I'm happy to come back, certainly on the data gathering from the ICB perspective. So Alan and I are also relatively new to the roles, but certainly from last month we did a big campaign around breaking down the barriers as part of Freedom to Speak Up, and we are capturing that information as people raise concerns around what the barriers might be at the ICB to raising concerns, and also when people do come through with a formal Freedom to Speak Up event, we are also capturing that.
Thank you. Does anybody in the room have a question?
Yeah,
I can see you clearer now.
Hello, yeah, it's Cecilia.
Cecilia? Yeah,
just
go on.
Just follow up with the issues about themes. I'd be interested to understand what the sorts of themes are that are coming through. And because I think that there will be some people who will not feel that they want to whinge about a work-related issue, you know, working long hours, gaps in service. Is that something that should be being reported? because it's actually something that they're seeing as situation normal. You know, we're often stressed and stretched, but it does have potential patient safety implications. It does have potential staff burnout issues. Is that something that they would report through this route, or is it clear that that is the sort of thing that would go this way rather than another route?
Shall I come in on that, Jenny?
Yes, please.
Yeah.
Yes, please.
Really good question there, Cecilia. So each partner organisation will have their own mechanisms for triangulation, analysing the data as suggested by Rhiannon, the equality data around that, almost a heat map of their own organisation, and within that heat map, what are the cold spots where we're not hearing anything? The way that the ICB board gets oversight and assurance on that is through the People and Culture Committee route, and that's the main place for the analysis of that data, because freedom to speak up Guardian concerns are one KPI of the broader basket of measures which give us insight into the culture of organisations and our system. So that basket of data is looked at as an overview for our system through the People and Culture Committee.
It's to the point of, if I've got what I see as a work-related whinge, you know, I can see my colleagues are overstressed. Is that a freedom to speak up issue, or is it not? And how would I know?
So there are multiple channels, routes to raising concerns, and freedom to speak up is just one of them. So whilst on the surface I'm overstretched might not appear to be a freedom to speak up route, if my line manager is not listening to my concerns and taking that seriously, then then I may choose to use the freedom to speak up guidance to help me get my voice heard.
Super, that's great, because that's what I'd assumed was happening, but it wasn't.
Well, and that's the theory. Of course, every individual organisation and partner around the system will be closer to what's happening within their own organisation, and it'd be interesting to hear views.
And Dawn, your basket of measures, does that include what Rhiannon asked around the patient safety issues that are going through different routes? So would it also appear in that basket of measures? Because Rhiannon did ask about the triangulation.
And that's where the triangulation, if we take our committee structure, that's where that cross-referring and triangulation of for example, quality committee data and people and culture data comes in, and that's the benefit of having consistent people on these committees to pull that in together.
Perfect. So that's probably a good point to go to Debbie. So I'll go Debbie, Matthew, and then Siobhan.
Thank you. Really important subject, and I think a lot of my things have actually been raised, so I'm not going to duplicate. But I think building on the triangulation, I think I think it would be really helpful if we make sure that we have a freedom to speak up report coming through our quality committee that actually just pulls together any themes from across our system, because then if we actually have themes coming in from freedom to speak up, we can then triangulate that with any other areas of quality concern that is coming through from other reported mechanisms. So that's kind of one way to triangulate, I think. So I think sort of that's helpful, and that kind of builds on what I was going to raise actually around. I'm assuming that we've started to develop a network of freedom to speak up guardians across our system, and I think having that network and then actually regularly meeting so that you can actually share themes, obviously not sharing individual details because obviously they'll be specific to individual cases, but to share any sort of themes that are coming out across our system, and any learning to make sure that, you know, learning from one organisation can then be shared with another before we get to that point, so we can actually sort of share best practice before we're waiting for people to need to speak up. So that was all I was going to say. Thank you.
Thank you very much, Debbie. Matthew?
Yeah, thank you, and I'm sure Siobhan will come in a similar way in a moment. But I just wanted to say this is a great topic to bring to this board today, because it is such an important issue, and in providers, this is a really important issue. I've worked closely with Freedom to Speak Up Guardians since the launch of the service, which I think was something around 2015 or 16, something of that order, and I think the really important thing to have in our minds as a board is that one of the things that the Freedom to Speak Up service does is it provides a safety valve, really. So that question about should I raise this here, should I raise it there, from my point of view, I'm not really interested in that question. I want people to be able to go to the Freedom to Speak Up service with whatever they feel they need to go with. As it happens, we did, as Dorset Healthcare and Dorset County, we did our Freedom to Speak Up training yesterday as two boards, so NEDs and execs together, doing the I think it was the level 3 training for Freedom to Speak Up. And so what our guardians told us yesterday is I think the split that they're seeing at the moment is about 75-25% in terms of about a quarter of things present as patient safety issues and about 3/4 present as other concerns, which might be about gaps in staffing, but they might be about kind of cultural or sort of, if you like, HR concerns. But of course, there's a direct relationship between those things and safety. You know, if your climate isn't right in the team, then you often don't feel comfortable to speak up. And so if there's a safety concern, you won't speak up. And the way that this was described really well to me by Henrietta Hughes, who was the first national Freedom to Speak Up guardian, is that in healthcare, and I'm sure you know most people on this board will know this, but healthcare is such a complex environment to work in, that in every organisation there will be corners that you don't see of that organisation. And again, the Freedom to Speak Up service is a way of being able to shine light on those corners. And of course, the issues that have been raised today about looking at the data to make sure that you're looking for the places that you're not hearing anything from, or you're looking at groups that might find it more difficult to speak up, and actually taking steps to then make sure that you're having conversations with those groups and those individuals in different ways. All of those are important points. So I just really wanted to come in with that provider perspective and just to support what an important issue this is.
Thank you very much, Matthew. Siobhan and then John.
I won't
repeat
what Matthew said, but I totally agree. And I suppose I was sort of thinking at this in many ways. One is obviously this is just so incredibly important in terms of us developing our compassionate, inclusive culture across the integrated care system. And within UHD, we've been doing quite a lot of work on the sexual safety charter as well, which I noted is in Patricia's report. But also it links in with Schwartz rounds, the staff survey, the triangulation of all of that data. And I think we're really lucky because our Freedom to Speak Up champions are brilliant. And actually, I really want to thank them for their work, but it is everyone's business. And I suppose it made me think, as an integrated care system, at the moment, this is quite a health provider focus. And if you look at our board papers, every 6 months we have a very detailed report with themes, with actions, with the learning from what is coming from our Freedom to Speak Up. But actually, I probably couldn't, I don't know what happens in other providers across Dorset or anywhere else, actually. So I suppose one of the questions running through my head is, as we're evolving and developing, how do we take this to a next level in Dorset where we have a system overview of the themes and the issues? Because I think actually it would be really interesting to see that across our whole system.
Thanks, Siobhan. It was going to be one of the points I'm making, summing up at the end, so that's really helpful. Jonathan.
Hi, yeah, I echo everything about how important this is. From my experience of with my journalistic hat on, when I was investigating these things as a health correspondent, what I found was that, and I think we're really talking about the extreme end of this continuum, is that where things went wrong was not people not speaking up, but the skills in the organisation investigating those complaints and the biases in the organisation. And if you look back at all the most egregious cases, there's usually someone who's spoken up, but the organisation, for one reason or another, has dropped the ball in the way they've actually investigated it. Now, that's really hard, because you understand all the biases. But so my question is, what training is there available? Because, I mean, obviously these can come into multiple people at multiple times. And is there any sort of provision for sort of almost like an independent or a quasi-independent way of investigating somewhere you think, okay, we need someone with a different perspective or a different way of investigating? And the reason journalists often uncover these things is they don't have the biases, and they'll talk to everyone. They'll build a broader picture of something that's going on. And is there something about not only encouraging the culture, but also encouraging a mature culture of investigation as well, which is really different in organisation? And you'll see that with the ICB thing, that culture of investigation had all sorts of issues there. And it cuts both ways. You want to protect the staff, you want to protect in the ICB, you want to protect the nurses, they felt they're being bullied by the clinicians, and there's all sorts of things. And sometimes you need someone who can step outside the organisation to investigate. And I just wondered whether that has ever been considered.
Thank you, Jonathan. So I'm going to go back to, I don't know, Dawn or Charlotte, who wants to answer that. But I think there are three things. There's Jonathan's question that he's just asked. Debbie suggested that we bring a Freedom to Speak Up report to Quality Committee. I think that would be a really good idea. So good if we could have a response to that. And then the point Siobhan made, which I was also going to make, which was, how do we find out what's happening across the system as a whole? Because what we've got today and from that video is a presentation from health, but it doesn't give us an insight at all around local government, around primary care, around the VCS or anything else. And I think all of those things kind of link to the point Jonathan just made. So who wants to pick up on those? Dawn, shall I come to you or shall I go to Charlotte?
No, please, I'm happy to speak to this, and thank you everybody. I think that's been a really valuable discussion, and I think it's helped us almost consolidate as a board where we want to take this agenda, which presently, whilst we do have some oversight, the whole board doesn't necessarily get the same visibility on that. So I think bringing that system overview of themes is going to be really important, and as part of that, I think it would be quite useful to bring what's happening across our system to develop those skills in listening up, receiving concerns, and in that early resolution. I'm going to take some time to consider Jonathan's point about independent investigations. There is something about the importance of early resolution, and if our speaking up culture is healthy, then speaking out, early resolution, moving to action, nipping in the bud is ideally our direction of travel. Of course, there will always be the need for broader investigation, but there's something about if we're having to go down an investigation route consistently, then potentially we're going wrong somewhere at the earlier stages. So I'm going to take that thought about investigations and just give it a little bit more considered thought with my colleagues across the system. Does that answer everything, Jenny?
That's fine. I've got, I think it's Graham. I can't really see, but Civic Centre room. Is that you, Graham?
Yeah, hi, Jenny. It's Graham and Vicky. We're both in the room here.
Great.
Thanks.
So one of you got your hand up.
Yeah, thanks. We've got some quite comprehensive arrangements in place. Well, I just wondered about whether it's worth doing is just create a table of what are the arrangements in each of the organisations. Let's compare and contrast, because that might help to identify where we've got gaps or where other people have got some strength or expertise. But we've got really strong staff networks. Vicky and some of the members are involved in some of those. The leadership team are involved with some of those. So we've probably got some comprehensive arrangements. But I bet when we mapped ours and we mapped what the ICB is doing in ours, we'd find there were some gaps in ours and potentially some areas that we do that others don't. So I think if we could, across the whole system, just get an organisational analysis of what are the things you've got in place, that might be really helpful.
Really helpful. And I don't know if, Dawn, if you can work with CPOs across people across all of the people professions and do that. Matthew, you had your hand up, it's gone down. Are you happy for us to move on?
Thanks, Jenny. Well, all I was going to say is briefly, it's probably also worth thinking about when this issue might come back to this board in the future. I think this is a very helpful discussion today, but we also need to recognise that this is an evolving space. So, for example, from the provider point of view, all providers at the moment are doing a national assessment against a range of freedom to speak up standards, which go through our board to report. We do report regularly at board, and cases are reported on an ongoing basis to the National Guardian's Office. So I was sort of thinking, if we got the ways of working going that you've described, building on the discussion today and bringing something back through the Quality Committee that almost takes a view across the whole of the integrated care system, I would think that a discussion in sort of 6 months' time or so about, okay, well, where are we? What are the themes? Where do we need to go next? Might be a useful thing.
Yeah, and that sounds sensible. And I'll leave Debbie and Rhiannon as the kind of Quality Committee people, and Dawn and Lisa as the People Committee, to have that discussion around appropriate time to bring it back. So thank you all very much, and thank you, Dawn and Charlotte and John, for bringing that today. At the start of this, it's led to quite a lot of discussion, so and really useful stuff. And I think it gives us a good point to move on to the Chief Executive's report. So, Patricia, your report is here to give us an update on the current local and national developments. They're set out in your report, but I'm sure you'll want to introduce, and there may be additional things you want to add.
Yeah, thank you, Jenny. So I'll take the report as read. There are just 2 or 3 things I just want to bring to everyone's attention. Obviously, the impact of industrial action, and that's making it incredibly difficult to deliver on the elective care targets. There's a national conversation happening continually about what the threshold for delivery of elective care should be, given the lost activity through industrial action, and we will have incurred significant costs, like lots of other health systems, in providing cover during periods of strike action. At the moment, the latest update is that the consultants are in talks with DHSC, which is why industrial action has been suspended for a period of time. So I think we just all need to hope that that gets resolved and we move forward in a more positive way. There are ongoing discussions between NHS England and the Treasury about how that additional cost will be met in terms of the impact of industrial action. You'll know that we've been a pilot site for the first system pilot for the CQC assessment process. That is now concluded. We've had some initial feedback, and Jenny and I have written to many partners just to give an overview of that feedback, bearing in mind that we haven't yet had the draft report, which we're expecting just before Christmas. We'll have 10 working days to respond to any factual accuracy concerns we have. The actual report, the final version of the report, will not be published until the spring, probably in March, because a second pilot assessment in Birmingham has only just commenced, and the CQC would like to publish both reports at the same time. And then I've articulated in the report some highlights of risks going forward up until the end of this year, and maybe some priorities that we might want to focus on. The one thing that probably I haven't listed, which came up in our Dorset Chief Execs meeting this morning, is that as health is financially constrained going through to the end of this year, and when we develop the medium term or finalise the medium term financial plan that takes us to 27-28, and our local government partners are also facing some financial challenge, that maybe a meeting in December would be really helpful to understand what actions we're all planning on taking in terms of cost improvement and transformation, and where there might be some flow-on impacts that we might need to consider how we respond to those in the new financial year. So I'm happy to take any questions.
Thank you, Patricia. So are there any questions or comments for Patricia? Debbie?
Just a comment about the CQC. I think obviously, as Patricia says, we await the formal report and then our opportunity to do faculty advocacy. But I just wanted to say that generally we were pleased with the initial feedback that we've received, and the consensus from CQC that we understood as a system where our strengths were and where we have still got work to do. So I think that the initial feedback was very on par with what our thought process was with regards to where we're developing and where we're still sort of immature as an ICB, as we would be. We've only been an ICB for 15 months and a system for that long. So I think sort of generally, I just wanted to say that you know, we're pleased with the feedback we've had, but we obviously wait the full report, as Patricia has said. So.
Thanks, Debbie. And can I use this as an opportunity to thank you and Jane and the rest of the team who had a phenomenal amount of work to do beforehand and actually during the pilot inspection also. And the feedback from the CQC was that you were the dream team to work with. So and I know that wasn't said lightly. So thank you very much for that. Okay, any more questions for Patricia? I've got one then. It's not really a question, but I guess it's a request, because Patricia has extended her report to all partners so that it's a more holistic report. I noticed this month that we don't have anything on primary care, and I think we still haven't managed to get anything from the ECS sector. So if I could just encourage all partners to think about what they can contribute to Patricia's report, that'd be really helpful, because it's good to get a rich picture of what's happening across the system. Okay, let's move on then to quality reports. And Debbie, this is your opportunity to tell us what the key quality and safety issues are across the services that are commissioned by NHS Dorset.
Thank you. Like Patricia, I'm going to take the report as read. Hopefully it's written in a clear way that is fairly self-explanatory. I think you'll note, and obviously Dean's going to give us a separate report, performance report, but you'll note that a lot of the quality and safety or potential quality safety concerns that we're concerned about are in relation to performance and meeting the standards that are expected around our performance. And that's not something that is unique to Dorset, but is a national challenge post both the pandemic and industrial action and other capacity challenges. So I think just to let you know that we are proposing and planning and work is underway to actually produce an integrated performance and quality report going forwards, and we're hoping to have the first version of that coming to Quality Committee in December. So just a sort of slight change in direction, so that we can actually pull the two together and we can triangulate and look at our performance report and then have to say what impact is that having on patient experience, patient quality, patient safety. So just that's just a slight change of direction that we're working on, and we'll be coming to the board as soon as it's ready, but Quality and Safety Committee in December. So just a couple of things I wanted to highlight. I was going to highlight around the CQC, but Patricia's done that in her report and we've already mentioned that, so that's great. One of the things that's really difficult with regards to the waiting lists that we're all experiencing within elective care and follow-up at the moment is really sort of measuring impact and patient safety and patient harm, and we're grappling with that, as is everyone across the country really. And what we've decided to do is to try and do a bit of a deep dive into patient follow-up and potential serious harm and actual serious harm that actually we've found, which might not be that apparent for a few more months, to be honest, but actually we are doing a bit of a deep dive, and system quality group is going to take that forward and work across all partners to actually see how we can start capturing some of that information and most importantly taking action across the system to actually try and prevent whatever we're able to. As the report says, we continue with our MAID events. They've become a bit business as normal. We just do them in different areas, and we've been continuing our MAID events across our mental health service with some really positive learning and actions taken from each of those, which are being led by the Home First programme and Dean's team to actually make sure that we sort of really kind of embed the learning not just on that ward area where we're doing the MAID event, but across the whole sort of sector. I think the only other thing I was going to say was around the shared learning panel. I mentioned last time around how well that's working and how we really are sharing learning from our serious incidents across the system. Obviously, we're moving to PSEF, and there's a separate paper on that later today. But I think I just want to draw your attention to an example of the shared learning that we've put as Appendix 2, which is the sort of way that we try and capture learning from our primary care colleagues on sort of a one-page sheet that goes onto SharePoint and then is shared across all primary care, and there's an example one in the papers. So I wasn't going to say anything else. I'm just happy to take any questions if that's okay.
Thank you very much, Debbie. And Jonathan just got his hand straight up, and Rhiannon. Jonathan, you look frozen on my screen. All right, go for it.
I'm very excited about the hydration pilot, and my question is, I know a little bit about this, and last night I looked at all the academic evidence, and we have clearly replicated in the first pilot what Devon did. It also replicates what a 30,000 people study in Wisconsin did, and another study in Norway. So my question is, how much evidence do we need before we do the agile thing and say we should just do this across everything now and put some money into it? I mean, the figures are consistent in all these studies. But if you get water into people, they don't fall down and they don't get UTIs. It clearly works. It's clearly a low-cost intervention. What point do we just say, look, there's enough evidence, let's just do this? And how much evidence do we need? Yeah.
Do you want me to come back on that now, Jenny? So I think we had that discussion at Quality and Safety, to be honest, John. And I think you're absolutely right. And I think what I would say is that actually we are doing so. I think sort of this is being pushed in all of our acute trusts, in all of our community provider wards, and across most of our care homes. I think what we were trying to do with regards to the pilot, I think, is capture the real data of improvement. So capture the impact, so that we can really evidence the improvement. So that we can actually then promote it even further across our care homes. But I think you're absolutely right. It's a bit of a no-brainer, really. It's really what, and quite often it's quite hard to read it and not think, well, that should just be happening anyway. But the reality is that it doesn't always. So we do need to keep encouraging it. So. Yeah,
but that 67% reduction is consistent across all the studies.
Yeah, it is.
And that can't be a mistake now. There's too many being done.
Okay, thank you very much. So I'll go Rhiannon, then Forbes, then John.
Thanks. I just wanted to, I suppose, amplify Debbie and thank Debbie and Dean for working on this integration piece, if you like, between performance and quality, because I think it's crucial in terms of those not being seen as separate. So I just wanted to thank them for the work that they're doing in bringing that into the quality safety space, and obviously anything that needs to be escalated. But I did have one question, Debbie, and it wasn't one I particularly spotted at Quality Safety Committee. So it's in relation to the suicide prevention, or suicide deep dive and prevention. And my question, I wasn't clear whether the harm was happening in inpatient settings or in other settings. And the reason I suppose I was particularly wondering about that because my follow-on question to that would then be, so where are we with things like ligature audits that are obviously really important if we've got that kind of harm happening in inpatient settings? So it was just to get a sense really of what the setting for that harm that obviously is concerning, obviously.
Yeah, I'm happy to come back on that specific if that's okay. And Matthew may want to come in anyway, because it's obviously a Dorset Healthcare prevention survey. But I think that the harm is largely outside of the actual increase in suicides by hanging is outside, not in our facilities. That said, there are ligature attempts continuously within our inpatient wards, and there will be across all of mental health services, because that is the challenge that is faced. And I know for a fact that regular ligature audits and also CQC visits and assessments to check on compliance around ligature across all of our mental health facilities is a regular occurrence. But I don't know whether Matthew might want to come in on that at all.
So specifically in terms of ligature incidents, this is something at the Dorset Healthcare Board that we look at as a key metric every time we meet. It has reduced, and some over the past 12 months or so, some really good focused work has been done around ligature incidents and learning from them. It's been a great piece of work with estates colleagues working hand in hand with clinical colleagues. And in fact, we've been asked to share that work with some other trusts by, I think, the CQC and the regional team, and it got nominated for an HSJ Patient Safety Award, which was great. So it's never enough. And I was on one of our inpatient units the other day, and just hearing from the team about what else they were doing. So I think that this is a broader issue that's referred to in the report, and it's obviously a really important topic. I mean, at its broadest, suicide prevention is an issue for the integrated care system as a whole, and we need to be looking at that in all settings of care.
Thank you. Okay, so I'm going to take Forbes, John and Patricia, if I just take them in order, and then if you come back with responses after that. So Forbes, John and Patricia.
Okay, thanks, Jenny. Two things. First was really just to support Jonathan's comments around the hydration pilot. Equally to support Debbie, I did think that was sort of business as usual. But you know, if we have to constantly reinforce it, then let's do it. You know, we're very keen in the Alliance to promote our self-help message through the winter, and I think that would be not just keeping warm, but actually maintaining hydration would be a good thing to add into that. There was quite an interesting thing on the radio last night, actually talking about the use of AI in care homes, and there's some process where people who can't communicate effectively, whether they're in distress, and through this AI tool, through facial recognition, they were able to reduce pain scores significantly and reduce the prescribing of antipsychotics. So just as an aside, it's quite interesting things that might be available to help in that area. The other point I wanted to ask about was the IT issues at UHD. That is of concern, and is, you know, I see Siobhan nodding, and you know, is an ongoing issue. Quite honestly, it's not really a new issue, but actually does have quite a significant impact on colleagues' ability to deliver care. And the message is we haven't really got assurance, and we haven't really got an easy way through this. I wondered if perhaps Siobhan, and I guess I know Stephen has a view on it, but perhaps we could hear from them, please.
Thank you. I'll go to John and Patricia first, and then we'll pick those up after. Was that you trying to come in, Siobhan?
Yeah, I don't mind when though, Jenny. It's fine. I can come in at the end.
Yeah, that's fine. We'll pick it up after. So John and Patricia.
Like Forbes, I was coming in on 3.5 about the clinical IT issues. It felt there are some urgent issues and then some important themes. And I wanted just to hear about what are we doing now to deal with the misdirection of results, and what are we doing around, you know, making sure that we're not, have we got the mitigations in place now that deal with harm that could be happening right now?
Thank you. Patricia?
Thanks, Jenny. Just 4 or 5 things in my head. We had a system ICB, Southwest ICB Chief Execs meeting this week where we talked about the risk of harm because of long ambulance handover delays. And one of the things that we have agreed is that Michael Marsh will pull together the ICB CNOs and CMOs in order to work through an agreed framework for dynamic risk assessment. And I think we just need to note that in terms of quality and safety. And also that, you know, the report talks a lot about clinical assessment and deterioration, but there's equally a problem with poor discharge planning and deterioration and the harm that causes to patients. So I think we need to have some focus on the dynamic risk assessment, but I also think we focus a lot on the external issue around delayed discharges and not enough on the internal issue within providers around slow discharge planning and the fact that that cannot start when somebody's medical fit to discharge. It has to start as close to admission as possible, otherwise we are contributing to the harm that our patients are facing. I think there is, when we talk about the great work in this report that's been done on linking access to quality and safety, and it's great that we're doing this deep dive into follow-ups, I'd really like us to think more broadly about what happens when people are listed for surgery. How do we encourage clinicians to report as incidents when the deterioration, when they're waiting for a long time on a waiting list, leads to a more complex procedure because of the length of time they've waited? And I'm not sure we've actually got a handle on some of that. And how do we report deterioration as an incident when somebody's been waiting for discharge? So we're getting the full NHS picture on the link to of operational performance and quality, not just patches of it. And I also think we need to think about how we are gathering information on quality and safety issues across the entire system. You know, I hear all the time that there are huge issues in primary care, but they're not coming through at the rate that I would expect in terms of our incident reporting. And equally, if we've got quality and safety issues within local government and the third sector, then we need to understand what they are fully as a system, so we make sure the collective action that we're taking is the right step. So just to think a bit more about how we broaden this report out so it becomes a report that's wider and deals with more depth in terms of system quality and safety issues that we all have a responsibility then to try and resolve.
Thank you, Patricia. Some important issues there. So, and Debbie may want to come in on those, but yeah. How do you want to pick these up now?
So
Siobhan, do you want to come in first on the question to you?
I can do. I think across the system we're very aware of the issues within UHD around digital and the digital agenda. There's quite a legacy and long history of some of the issues to do with the IT systems across UHD. I would assure the board that the issues that you've brought up there's been an external piece of work which has identified some more rapid work that we can do around closed loop reporting and developing our e-forms, which we are doing. This is within the risk register of UHD. There are a number of mitigations, primarily led by Peter Wilson, our medical director, and this is also then assured within the organisation at our quality committee and our FPC, and is obviously an item for the board. The real solution, and not the mitigations, will take some time and is part of the EPR programme that we're working on across the providers in Dorset. But as everyone is aware, we do have a burning platform at UHD, so it is very important that we are implementing an EPR from May 26th.
Debbie, do you want to add anything to that and the others?
Yeah, I think no, I think that sort of captured the IT. Certainly share your view, Patricia, around the deterioration on the waiting list and the sort of whether patients are receiving more complex procedures and how we're really capturing clinical harm. from all elements of our challenges at the moment. So we really are looking at that, and this is one deep dive. We've already done a deep dive for SQG on some clinical harm around the waiting list. So we'll keep looking at how we can actually make sure that incident reporting is really high in these areas and that it's really being captured. Excuse me. And then I share your concern and the need to increase our visibility of incident reporting from primary care and local authority colleagues, so we get actually the true sort of picture right across our system. Moving on to PSERF and as our practices move on to the learning from patient safety events sort of network database that allows the ICB to actually view incidents in primary care from primary care firsthand. So actually, as all of our practices begin to sign up, and we're getting quite a good level now, that will actually help us to do that as a system. So, and also to help us identify practices that are potentially under-reporting. So we'll have a bit more visibility, which I think we've been kind of lacking at the moment. So I think that's it. Thank you.
Thank you very much, Debbie. And I think that's kind of almost a good segue into the next agenda item, which is the finance update, because it is looking at how we're performing as a system financially, but also what issues are being and need to be escalated to the board. So, Rob, can I hand to you to take us through, please?
Yeah, thanks, Jenny. So I was trying to think what's the best way of presenting this. I'm going to try and do it in two sections. So the first section, there's a table in section 2.2. I'm just going to talk about that table first of all, and I think that gives a very good overview of the NHS position. I'm going to apologise as well up front now. We've been trying to extend this report slowly to include other areas. I think this just reflects the pressure that we've got in the NHS on the finances, that actually the team, it's an NHS report, so apologies for that, but it just covers the NHS position. So the table that we've got there shows that as at month 6, we're reflecting a £20 million year-to-date deficit. Good thing is that's easy to double to 40 million to get to month 12, isn't it? You know, the maths isn't too difficult on that. So that suggests that that's quite a large deficit that we're facing at the moment. Whether or not the number's 40 million or not, we're going to talk about it in part 2 a bit more about what we can do, etc., etc. But what this really reflects is where the cost pressures are occurring and what the reasons for them are. And if I just start off by saying we knew when we set the plans, especially in our providers and in the ICB, that we had some large stretches and risks. One of those in our providers was inflation. We knew that we got contracts signed that had inflation baked in that was more than the funding available. So we knew that some of these risks might start crystallising, and then you have to think about how do you mitigate them. Now there's a few columns on there, and one of the columns says impact of industrial action, but what I'd like to talk about is industrial action more in its totality. So first of all, if we looked at some of the things that we knew were risks that might crystallise, the column that says inflation not in the plan, halfway through the year it's running at just under £4 million, so 4 million extra inflation than we had funding for in the plan. Then there's a column that says other, which is a couple of million, and then we're offsetting that by some vacancies. Now, if you add those 3 columns up, that pretty much comes down to a net zero position. And what I'd suggest then is if we think about all the other columns as links to industrial action, okay? So at month 5, we had a 10.5 million year-to-date deficit sitting in the providers, and it's 20 million in month 6. That's a huge increase in terms of the run rate. Last month, I did mention to the board that we were working through the impact of the electric recovery funding, which is effectively, if you do the work, you get paid for it. And we had a bit of a problem because a lot of the work was being done in the independent sector, which means that we pay them and not our NHS providers, and it causes a hole in our control total. That's been worked through now with the region, and we're reflecting that income loss. Because we haven't been doing the activity in our NHS providers, it's been done in the independent sector. So the main reason why the numbers jump from 10.5 to 20, 8 million of that is on the far right column, it's the ERF PBR impact. Okay, so we've now quantified the lost income that we had in the plan for our NHS providers because the activity is not being done within our NHS providers, and that causes the problem in our control total. So first of all, why aren't we doing the activity? Well, quite a lot of the reason for that is because we're either planning for industrial action or we're in industrial action. So across the country, activity is lower than what was hoped for and expected for. So that is linked to industrial action, that £8 million. The left-hand column talks about the impact of industrial action. That's just the extra cost of industrial action. It's not the full cost of industrial action at all, though. It's a reflection of, there's a template we have to work through, and it kind of calculates what we'd say that's the cost of industrial action. That's £3 million. So those two items on their own is £11.2 million that is linked to industrial action. But of course, what you then get into is all the knock-on effects of that. So we've also got a line around efficiency shortfall and agency costs and escalation beds. Again, I'd argue that it's not as binary as it's all to do with industrial action. It isn't. I'm sure that we would also have variances there if we didn't have industrial action. But the simple fact is, if we want to deliver our cost improvement programs, you need a lot of clinical engagement. It's very difficult to get clinical engagement when the clinicians are planning or in the middle of industrial action. So again, across the country, there's large shortfalls on the efficiency programs as well. And that normally means as well, when you're having your industrial action, that your agency costs go up as well. Again, I'm not saying it's all to do with industrial action. We know that we've got a bit of a problem with agency, and we've got that as one of our projects, but it's definitely linked into that as well as escalation beds as well, because we just can't get the system flowing properly because it's stop, start, stop, start, stop, start. So the 20 million, if you assume that the inflation, the other offset by vacancies is roughly net nil, you can probably say that 20 million is largely related to the industrial action. That's probably not the whole truth, though, because actually I'm sure we'd all pretty know that if we didn't have industrial action, we would still have a variance on some of those lines as well. We know that there's some of the things that we need to go after, but that's the kind of the position in the providers. The main thing that sort of like puts us a bit on the radar with the region, though, was the jump from 10.5 to 20 million in 1 month. If you stripped out the 8 million, we only moved 1.5 million, and 1.5 million is actually an improvement in our run rate. So if you look at the sort of like stripping out that lost income, we were making a slight improvement on our run rate, which is actually a bit different to lots of other systems as well. So that's the good news, but we have to reflect now the fact that we've lost the income, we won't be earning it, therefore that's real, so we have to dial that in. So that's the first part, and I've really been talking about the overall NHS provider landscape there, the fact that we're sitting on a sort of 20 million in-state deficit. In terms of the ICB, we still hold and report break even. Dan will no doubt, when we get to the escalation report for FPC, talk about the PHC, so I'll introduce that at the moment. You'll remember again when we set the plan that we had a sort of a £40 million risk in the ICB as well. And again, you probably think, well, halfway through the year, maybe we should be recognising 20 million of that risk if we think that it's all going to crystallise. We're working through in a lot of detail now what those risks are, and the majority of those risks lie in prescribing and PHC, so personal health commissioning. Personal health commissioning in the report is running at about 28 million overspend. This month, the latest numbers, it's gone to 30 million, and I spent a couple of hours going through the forecast just before Finance Performance Committee, and the bad news was actually it looks like it's correct. Always hoping that there's errors and things, but it wasn't. It's actually right. And Dan will talk about the FPC escalation to the board around PHC, that actually there comes a point when you know that we have to find another way of funding that. The other pressure that we've got, not as large as PHC, is in prescribing. Again, that's seen across the country. It's an interesting one. One of the big pressures we had last year was no cheaper stock obtainable. So that's when you run out of stock. And you normally have to pay a bit extra prices for replacement drugs, and you get some funding come down to help you for that. As the drugs have come back into stock, the tariff is increased. So although they gave you the money last year, that was non-recurrent. You don't get the money this year, but the tariff is increased now, which reflects what the cost pressure was last year anyway. And we now have a no cheaper stock obtainable problem in year as well, which was like the one last year, which we kind of hope we might get some funding for, but nothing's been confirmed. So you almost get a double whammy sometimes on these things that come through. You always pick up a sort of a legacy cost pressure. So at the moment in the ICB, we are still holding a break-even forecast. I spent 2.5 hours with region finance colleagues yesterday where we were going through the forecast, what it looks like. There's some national calls later on today where we're going to have some updates on the finances as well. So I think we're just moving into that part of the year now where we start getting more clarity around what funding is likely to be, how we're going to be dealing with industrial action, etc. So I think the task that's going to be facing us over the next few weeks is that after we've had the phone calls this evening, we'll then run all of that through, and then we'll come up with actually something that feels much more solid. We know where we are, we know what the funding is, and we can actually then start really getting into what does that mean now for our forecast outturn. At the moment, we're reporting a 20 million, but we're not reporting any year-to-date deficit in the ICB. But we know that there are risks that are going to materialise and crystallise, as will be shown in the escalation report for Finance Performance Committee. Hope that was fairly clear. Any questions?
So I was going to say, Dan, that your committee escalation report covers off the PHC spend, doesn't it? So I don't know if there's anything you want to say now, though, or do you want to pick that up when we get to that item?
No, I'll wait till then.
That's fine.
Just thanks for Rob for a good overview of where we are. I know other people have questions, so I'll keep quiet.
Okay, Patricia.
Thanks, Rob. That was great. That was a really straightforward description of where we are. Just, I suppose, just a few points for me to just include in the conversation. So, yeah, with PHC spend has been going up quite a while, and Debbie's done quite a lot of work in trying to investigate why and where we might be able to do things differently in that service. So we're hoping to move forward with some changes really quickly that might have a small impact this year, but will definitely have a bigger impact going into 24-25. I think we need to focus on the things that we absolutely can control, not the things we can't. So we can't control industrial action. I think there needs to be a better understanding around the impact of industrial action in that, you know, when teams are spending half the month preparing for industrial action and the other half of the month recovering from it, there is not a lot of work going on around transformation and cost improvement, and that's the reality of where we are. So I think we just need to recognise that and accept it and work out how we're going to mitigate that. But in terms of the things that we can control, so the shortfall of elective activity is not all about industrial action. We know that now from the analysis that we've done. So we need to put some of our time and focus as a system into how do we increase our productivity, because it's not great. How do we improve our theatre productivity and efficiency, because again, it's not great, and actually it's going backwards rather than forwards in terms of a trajectory of improvement. And how do we tackle out some of our length of stay issues, because those things will get us closer to ERF payments. They will mean that we're performing better against the elective standards. And if we start to do the work on length of stay that we can internally, that gets us into a position of starting to release some of the beds that are currently open without any funding. So we've got to change some of our focus into the things we absolutely can control. The staffing issues that we've got are linked to are also really important around reducing the pressure on the system. And we've done lots of work trying to improve the system-wide recruitment that we've done, and then we're hitting barriers because the capacity to onboard lots of people at single points of time is proving really difficult. So looking at how can we address that, because getting more staff in increases our productivity and it reduces our agency costs, which are huge. So how can we focus on some of those things that move us into a better position? We've had a meeting with our system executive teams around the medium-term financial plan, and some of those things are in for the focus for next year. But I suppose my thinking at the moment is how can we accelerate that and put more focus on those things this year, because they could be the key to us getting closer to a much better financial position by year end, and also being in a better position in terms of where we start in April around the operational annual plan.
Thanks, Patricia. That's all really helpful. And Rob's summary at the beginning. I didn't want to interrupt you because you were in flow, but Dan said he couldn't hear. I just want to check. Is anybody else struggling to hear Patricia? Because you were really clear on my screen. Okay. So Dan, it might be, I don't know what to suggest, turning up the volume, but it might just be an issue for you, it seems.
Even
right,
would you
John,
log on again?
Sorry.
Stephen would just say, switch it off and switch it back on again.
And that often works. So there you go. John.
Yeah, thank you. That was really, really clear, Rob. Thank you. And I agree with Patricia's assessment about where we are and what does that mean into next year. Two just detailed questions. I noticed in 2.2, Rob, that Southwest Ambulances, they seem to be delivering on plan. I just wanted, I mean, that is, I was just thinking about the operational setting. I just wanted to clarify the Southwest Ambulance situation was number one. And then what I noticed in Dorset Healthcare, a really material vacancy, you know, effectively 5 million lower spend on establishment, I think, as a result of vacancies. And I just wanted to understand, is that giving performance, safety, or is there anything really to hear in that context? Because it really stood out compared to some of the other operators.
Yeah, so thanks, John. And I must admit, as Patricia was talking, I forgot to say we've got Andrew Rosser in the room, the finance director of SWAS. And I just want to thank Andrew from a financial point of view, at least, not causing us any problems at all. Operational might be different.
Operational might be different, yeah.
Which actually...
Don't mention the operational. Stay on the positive, Rob. Keep going.
Andrew can come in, but effectively, nationally, the ambulances were given some extra money this year to help. Okay. And across the country, it's not always in the same position as SWAS are. So financially, we're fortunate with SWAS. As I say, there's conversation around the performance, but I don't know if you want
thanks, John, and good point. I think it's fair to say that if we hadn't had that additional investment, we would probably be struggling to hit break even as well. But the share we got was 34.8 million. So that's quite a substantial increase for us. And we have spent that money wisely on increasing our frontline resourcing. Our frontline resourcing is now the highest it's ever been. And I think without that, our category 2 response times will be even more challenged than they are. I think performance-wise, we were doing pretty well up until the end of August, but then we hit the issue of increasing handover delays at hospital again, and also increased demand as the weather worsened. And well, actually, we had the hot weather, and then we had the cold weather. So all those have combined for performance to deteriorate again. But financially, yeah, we are still on track to deliver break even for the year end. Thanks.
Thank you.
Thanks,
John.
Andrew. So does that mean that that the vacancy level since October is better than that you've reduced that gap, that 5.3, because it does really stand out?
So John, just in answer to that, because we got the numbers fairly recently, and in the conversation with the region yesterday when we were looking at our forecast outturn, which again we might talk about more in part 2, that was one of the questions that we were asking ourselves about. What does that actually mean? Why is it only on one organisation? Chances are it's probably hidden in other lines on other organisations, but we just need to be clear about it so we can come back with a better position. In terms of, therefore, it's interesting that we just had the quality and got performance. There's always going to be an impact, isn't there, when you're holding the staff back as well. But through each organisation makes its own decisions, looking at the quality impact, etc., etc., etc. So, we take comfort in that, but we do need to see what that looks like across everyone to see if we're still assuming we can recruit the staff to help the agency, or actually if we're now going to, these are vacancies that we've had forever and a day and we haven't filled them, and actually now's the time to release them, which could also be. But I can't answer accurately at the moment, John.
That's fine. Okay, Matthews.
So thanks, Jenny. I mean, I think it's kind of probably a level of detail too far for the ICB, but from a Dorset healthcare point of view, I think what has happened is this anomaly is a legacy of COVID, and how kind of budgets have been managed through COVID, and what's happened to services. So I suppose I want to make a statement, which is that there's no holding back in terms of recruitment deliberately. There are certainly areas in Dorset healthcare where we're struggling to recruit, and then certainly that creates a problem for the running of some services. We see that, for example, for older people's psychiatry. But I think what has happened through COVID and sort of coming into Dorset Healthcare, and colleagues will know we've had a change in CFO, is that the usual triangulation that you would expect in normal times between sort of headcount and budgets and operational performance has been eroded somewhat. So we're going to be doing an exercise to tidy that up as we go into next year and make sure that we've got that triangulation as you would expect. That will be done explicitly and transparently with partners because it will be part of the system planning process. But the kind of bottom line from a pure financial lens is that if Dorset Healthcare were to recruit to all its vacancies, then it would have a significant budget deficit. So we need to address that structural issue.
Okay.
Yes.
Thanks for the update.
All right. Thank you very much. Thank you again, Rob. That takes us to a break. If we could be back in 9 minutes rather than 10, that would be really helpful. Let's start at 11:30. Thank you. We've already made reference to the performance report, haven't we? But this is for Dean to take us through the Dorset Health System performance and to raise any issues that need escalating to the board. Of course, the Dean has set out a paper and the various charts for the health performance, but I'll hand over to Dean now.
Thank you, Jenny. So I think for the performance report, just to link to what Debbie was saying earlier and the link between the quality report and the performance report, that will bring together really and mirror what we're doing operationally. And the reason why you see the two things mirrored in each report is because of the close working between our teams. And kind of Debbie and I were both at Paul Hospital yesterday with a full day going through all of the no criteria design. Some great learning from that, and hopefully has helped some of our patients as well. So that was a really beneficial. So it's a real natural way of working and bringing it together. So just on the performance report, I think we're not in a place where we would want to be with this. And at the moment, of the 24 standards that are in the operating plan, we are achieving 6 of those. And although some of those achieving those looks kind of a positive thing, it's not always. So we look at the amount of activity in primary care. We are seeing more patients in primary care than we anticipated, and that brings along kind of a great deal of stress for general practice as well. So I think just achieving these things is not always a good thing. It brings other challenges that we have. And when we look at the amount of activity coming through our front door in A&Es, during certainly September and early October, it's a lot higher than it was a year ago. We're seeing a different pattern of activity across the system. One thing that we didn't expect or didn't plan for at this time of the year was the amount of industrial action that we have kind of been talking about earlier on in the meeting. We've done quite a bit of analysis on the industrial action impact, and we can track that back that it's over 3% of elective activity has been lost this year due to industrial action. And when we look at the different types of activity, we can see that all of the underachievement that we've got on inpatient elective activity, so that's inpatient operations, can be wholly attributed to the industrial action. It's not quite the same for day cases and for outpatients, and it's about half the underachievement can be explained from that. It's different at different providers, but across Dorset, that's about the level, and that's what Patricia refers to earlier, and reinforces the work that we need to do on productivity on why that's happening at the moment. We're going to see an acceleration of that when we report the October figures as well, because of the number of days of industrial action, and it was both by consultants and by juniors, sometimes combined. We know that we saw maybe your reference there to somebody's not on mute. Thank you. That there is a reduction of 4.5% of elective activity during October, so that's going to accelerate those figures. So this isn't a place that we plan to be or wanted to be at this time of the year. So just a few headlines on how that has impacts on some of the areas. So in elective care, when we look at the report that you've got in front of you, when we I look at the more recent operational data that we've got, we're managing to at the moment to about hold our position across Dorset with the number of 78-week waiters and the number of 65-week waiters. So these are the long waiters that we've got. That's really going to be a struggle to continue to achieve during the rest of the year, but we are achieving that at the moment with about 50 patients currently over 78 weeks kind of waiting at the end of the month. Cancer, I mean, we have been doing pretty well with cancer, with the faster diagnosis standard. We have seen a deterioration largely due to 2 specialties, and we've had increased referrals quite significantly in dermatology, and they're a large part of the number of cancer patients. Now we have got additional activity that has been put on at both providers for dermatology, so we are expecting that to increase over the next month. And the other area where we've been challenged is on gynecology. There is additional activity again for gynecology that is happening this month, so we're expecting that to improve. Just linked to those, the diagnostic activity is one area where we do well. We're continuing to do well with diagnostics, and there are very few waits for diagnostic services. Emergency care, this is where we are seeing increased activity, particularly in the A&E departments. We have been doing pretty well with our 4-hour standard category 2 response times and handover, hospital handovers. We are seeing a bit of deterioration though with those in the last month. In some weeks we're seeing A&E attendances up 10%, in other weeks on last year. Other weeks it's kind of flat and the same as previous years, but not really dipping below at what last year's position was. The 4-hour standard, we are below now our trajectory for October, so that's not in the report because the report only goes up to the end of August. We are doing some work with UHD on that position, and we're going to do a review. Paul, as the Chief Medical Officer, and myself, we're going to meet with the department just to understand kind of what the challenges are and what other things we might be able to do to improve that position before we get to the winter. Hospital handovers, the agreement with the South Western Ambulance Service is that we should maintain no more than a 40-minute handover, because that should deliver a category 2 response time of 30 minutes. And we're there. We have just slipped, and in the last week we've just gone above 40 minutes, about 40.8 minutes we have gone to, so we're putting renewed effort on that. In mental health, we've had deep dives through our Finance and Performance Committee and through Dorset Healthcare. We have seen an improvement in out of area placements, although small. We have seen kind of more discharges than we have had admissions to that, but we're not down to 0 yet with out of area placements. I think that's probably all I wanted to highlight. Thank you, Jenny, from the report.
Thank you very much, Dean, and for bringing the report to life. So any questions or comments for Dean? Siobhan.
I suppose I just wanted to reflect that it does very much feel like winter, shall I say, the W word, and there is a lot of pressure across the whole system, and from our perspective, I think I was just I really welcome yesterday where both Dean and Debbie were part of the sort of team with our colleagues from BCP, really looking at the issues over patients still with no criteria to reside. And I hear it was actually a really positive event with really good engagement from a lot of staff, which is fab. And that actually we made quite a lot of progress thinking about pathway 2 and 3, which, you know, I think as a way of working, that is really good and very engaging. The other point I just wanted to raise is we recently had a GIRFT visit to Dorset. Professor Tim Briggs came and gave us a bit of a challenge, which actually was really welcome. What he did do, though, as well with the team was they highlighted where we're doing some things well. And I think when we're in the midst of actually seeing a lot of the challenges, it is nice to also hear where we are doing well in some areas. As a result of that visit, though, we are having a further visit from the team, the GIRFT team, to look at how we're using our theatres across Dorset. And I think that's really welcome. I think getting fresh eyes, people coming in, giving us a challenge, seeing how we can do it slightly differently. We will continue to learn. And to Patricia's point earlier, we have got work to do on theatre utilisation and productivity in Dorset.
Thank you, Siobhan. I think we need to fine you for using the W word, but we'll move on to, I think Forbes is next. I've got Forbes, then Jonathan, then Matthew, Rhiannon and John.
All right, thank you. First and foremost, I wanted to say that I found this report really helpful, Dean. I found it was very clear, actually, in terms of improving our understanding of the issues, and there's a long list of areas where we're underperforming. And I just wonder if, you know, I know there are lots of meetings looking at it, but I wonder if it's something we should look at in more detail through the provider collaborative. Thanks for your comments about general practice. I just wondered if you're able to give a sort of general overview on the sort of productivity issue and where you think the main issues lie. You know, Patricia's clearly said, and you've said, the strikes, the industrial action has been in place, but there are still productivity issues that we need to address. With regard to dermatology, I do wonder if one of the issues for the increase in demand in dermatology is actually the failure, particularly in the West, of the advice and guidance service to function. That's the best part of 12 months now. It's really not been functioning. So GPs really are left with no option if the advice and guidance service isn't working, but to basically initiate a referral, and very often it becomes a fast track referral, which we're all aware creates additional pressure on our acute colleagues. But if the alternative recommended pathway isn't working, there's nothing else we can do because we still have to manage the needs of that patient. Around virtual wards, we're involved in a very live conversation. Ben's on the call today about how we can work better with virtual wards, and that's a system conversation. But I just wonder if you'd comment on the productivity, please.
Dean, are you happy for me to take all of the questions, just bearing in mind if you just capture them and come back afterwards? So I've got Jonathan next. I can't actually see Jonathan, but his hand is up. So let's go to Matthew, and then Jonathan, if you can come in afterwards.
Thank you. Thanks, Dean. Really helpful report and lots of good work going on. I guess my question, which might be something to discuss in a future meeting rather than today, is can we, as time goes on, can we come back into this forum with what are the strategic messages from this performance report? So I think with performance, you've got a mixture of areas where you would want to focus with an individual provider because you think in the context of the current plan, better performance can be achieved, and there will always be those examples. But I think that there are some real strategic issues here that we will need to grasp going forward in terms of our system plan. So, here are a couple. For our no criteria to reside, have we got a good enough plan in place across all sectors of care, and is it sustainable going into the next financial and performance year? And then secondly, with planned care, whilst there's good immediate operational performance about the tail of the waiting list, again, have we got a sustainable approach going forwards that is affordable and deliverable in terms of our workforce and facilities? So I think for this board, as we head towards next year's financial and annual planning round, those are some of the key questions that we need to answer, and we need to be looking outside of the hospital setting as well. And that increase in activity in primary care is actually great because that's where we want people to be having contact with healthcare professionals and teams, but we need to make sure that they're resourced properly in order to support that.
Thank you very much, Matthew. And using chair's privilege, I was going to ask something similar at the end, Dean, because I think when you start looking at this report, well, I certainly took a sharp intake of breath around the sheer length of things that we're not meeting standards on. So I was going to ask a similar question. So I'd be really interested in the response to that. John, I think you're back on. Do you want to come in?
Yeah,
Jonathan?
Sorry, my internet had a fit. So I'll echo Forbes' remarks about how good the report is, but my attention was drawn to the very frank paragraph on the virtual wards section. It talks about the challenges. And I wondered if you had any reflections about how we introduce virtual wards, because it seems like we haven't brought quite a key stakeholder community with us. Or is it that actually this isn't the right solution for the problem and we've applied a solution to the wrong problem? Or is it a bit of both? Or is it we just need to reset and reintroduce it and introduce the way we've introduced virtual wards? I just wondered what your reflections are of it.
Thank you, Rhiannon.
Yes, similar theme here. So, yes, thank you, Dean. I particularly like the fact it's really easy to see at the first couple of pages where the list of this is where we're doing okay, and this is where we really have some work to do. I was also drawn to the virtual wards space, and it does feel like we need to get into a different layer of understanding, and maybe the point that Forbes made earlier might help. Is it that there's an anxiety about holding clinical risk in a space of a virtual ward? It's probably not one thing, I'm sure it's multiple things. Are we joining up our communications in terms of, here's the virtual ward space, don't forget, you know, it can help to support patients to keep them close, well, at home and closer to home. And the other one that I was drawn to was the talking therapies, just to understand whether the issue again is about awareness of making those referrals or capacity of the sectors that are dealing with those talking therapies to handle them. So maybe I missed it, but there was just something in that space for me as well. Because again, you know, thinking of matching communications to what's going on, thinking of seasonal affective disorder, you know, a good time to help some of those messages in terms of what matches the time of the annual cycle we're in. Thanks.
Thanks, Rhiannon. John, then Patricia.
I really had a step back thought, which is the one of the things I really noticed. We've really matured, and I think the team has really matured, Dean, because we're now looking at where we're seeing common cause variation versus special cause variation. And I was just reflecting that in a time of heightened operational pressure, if you like, actually great that actually we can use this to discern where do we go and intervene, where are the places where we really can go and make an impact. So my question really was, has the team now, is it really moving towards using charts like this to really say this is the areas of maximum impact, as opposed to, I think, what is probably an older mode, which is just responding to the reds, which is often common cause as opposed to specific cause variation?
Patricia.
Really good point, John. I think the team has matured and is looking at all the right things now. And Dean and I have been talking about how we move into a structure of relationship management. So we're really getting into the detail of where we've got special cause and what we can do about it. I think the report's really coming on. What I'd like to see, which I know the team are working on going forward, is a bit more of a commitment from partners around when performance is going to improve, so that the board really has the assurance that it needs around delivery. I think we really need to strengthen that link to quality and safety and harm, but not just in terms of the quality agenda for our patients, but also understanding as demand increases and we've got workforce challenges, what the impact is on our staff. Because there will be an impact for them in terms of stress levels and well-being, and how that links through into the people committee. Remember that we made some changes to the governance structure and changed the names of some of the groups and changed the remit of them, so they really are delivery groups. And I think we've still got a bit of work to do on agreeing with the SROs what the objectives are of their role in that delivery group, that really starts to take more responsibility for achieving the standards. Virtual wards, we've hit a bit of a cultural issue, but for me it's a bit of a no-brainer. You know, we're complaining about the fact we've got beds open that are not funded, and we're paying for a virtual ward service that's not being used. So whatever we need to do to stimulate the higher level of occupancy of that service, we need to get on and do it. And I suppose I'm asking our health provider chief execs to step into that space, because it feels a bit mad that we're not using those beds, and that is one of the answers to some of the pressures that people are under. And then I suppose the other observation is we talk a lot about acute standard delivery in this ICB, and not enough about primary care and mental health, and we need to start getting more of a rounded discussion going, because all that information is in the report. And you know, in terms of primary care, it's the bedrock of the NHS. If primary care fails, we really are in some very serious circumstances. So you know, how do we bring more of that forward? And also that, you know, what we've seen since COVID is a huge pressure and an increasing pressure on our mental health services. So if recruitment is one of the spaces that we need to get into more that is going to resolve some of those pressures. As we talked about, a more strategic overview through the report, how do we agree what some of those strategic priorities are to improve performance, and where we put our focus, and then really get on and try and deliver it.
So, Dean, some really detailed questions across the board there. And I'm not expecting you to provide an answer to all of them now, but go for it. Take us through how you want to respond.
Let me try and go for some of those, because that's quite a lot, and I suppose that's the benefit of having quite a detailed report. It kind of prompts a lot more questions. So I think, Forbes, first of all, on productivity, I think, was your question on primary care productivity or just productivity across the system? I think my system dropped out a little bit there, but
yeah, it's more about productivity across the system. I think, if I'm honest, I've heard more about productivity in acutes, and I don't really understand what the issues are. We've heard about the industrial action, but we all know there were challenges outside of industrial action and outside of COVID. I'm very willing to listen to anything or suggestions where primary care can do more, shall we say, but I would like to think we have increased our appointments. We are offering as good access as possible.
Yeah, and I think productivity was one of the main themes that we had when we met at Upton Hall as in developing our medium-term financial plan. Siobhan is going to kind of lead that work linked to our planned care delivery group. We've got our first meeting tomorrow to actually plan that work. We've got a lot of things that we can already draw on. So the GIRF visits is really helpful in that space. There are things, the high volume, low complexity work, the visit that we've had from Tim Briggs, but we know just from the visit that or the meeting, the kind of mega maid event that we had yesterday that Debbie and I were at, just issues around length of stay and moving people out of hospital. There are lots that we still need to do on kind of getting people into the right place at the right time, things that are not in the right place. So there will be a lot more on that, and we'll bring back kind of more details on productivity. I think Patricia makes a good point about, and linked to your point about primary care, there isn't much on that at the moment, so we do need to bring that back. And I think as we develop the report, we've deliberately kept this report so far to our operating plan deliverables, but as we move forward, we know that we have got our 5-year forward plan that we need to link, so that any of the prevention work that we're doing, we're seeing the impact of that come through as well. But we can add to this report for other things that we want to keep an eye on and show improvements. I think, Matthew, you make a really good point about what are the strategic issues. Yes, we can count the deck chairs, but actually, is the ship going in the right direction? So make sure that we have got that. I think we've done that. We're doing that testing, particularly around no criteria to reside. I think it feels like a bit of an onion though at the moment with no criteria to reside. Every time we think we've got to find out an issue, kind of you peel back and try and solve it, and you find something else happens. And I think that's down to kind of emergency care is very much a theory of constraints approach that you've got to take. It's kind of you fix one thing and see where it's going. What really came out yesterday was our trauma pathways, particularly in fractured neck of femurs. We have got more people waiting for therapy in that situation than we thought we had. When you draw it together yesterday, it's clear that we need to look at that pathway for trauma patients and those that have had fractured neck of femurs. Jonathan, virtual wards, Patricia's already mentioned it, and I think Paul will probably come back in, but there's a cultural issue around that, and it's something that we addressed at the system executive group, where all the executives got together kind of in the last couple of weeks, because it's one thing that we need to solve, because we have got capacity there and we need to use it. The talking therapies one, Rhiannon, it's clear kind of we're not meeting those targets, although nobody's meeting those targets. They were probably designed for a different time, but we're going through that with Matthew's team to look at all of the mental health areas and really seeing what is realistic at the moment. So we are working through that one. I'm really pleased that you've picked up, and it's coming through the report, the fact that we're using SPC. We're probably not advanced as some of the others, and we saw some great graphs yesterday from Siobhan's team in UHD, really tracking through that no criteria to reside position, and you could see the intervention points that we had when we changed kind of the counting, when we've had certain interventions, and there has been a change in the SPC charts that means that we have got improved performance due to that. And the last point, I think, Patricia, on more mental health and primary care, yes, we will look to extend the report to include something else on those. I think I've tried to cover everybody's points.
Yeah, you have. Well done. Now I can see hands going up again, but we are way behind time. So Paul and Matthew, unless it's something really burning, I'm going to suggest we move on. Matthew's loaded his hand. Paul hasn't. Oh, you have. Okay, so let's move on. Feel free to pick them up with Dean outside. So I'm as guilty as this as others today, but just a reminder that this is a meeting in public, and we've all been using lots of acronyms. I don't know how accessible those are to members of the public. So just as we go through the rest, if we can just remember that and try and use a longhand if we can. So we're now on to the committee escalation reports, and we're going to start with the Clinical Commissioning Committee, which is Jonathan Carr-Brown.
I'm going to have to pass this over to Kay because I wasn't actually at the meeting.
I've got Kay did it for you, didn't she? Kay.
Yeah.
Sorry, I'd forgotten how it's the clinical commissioning. You're going to get fed up with me because I've got to report on people and culture as well, because Lisa's not here, and then I've got my own one for primary care, so give me a minute to look back at. I'd already gone ahead to the others, to clinical commissioning. Sorry.
Do you want me to come back to you then, Kay?
Yeah, could you?
Yeah, that's fine. So let's do finance and performance. Dan?
Thanks, Jenny. I try and avoid the classic thing of saying take the paper as read and then talk about the whole paper. There are just three things to pull out. FPC had a really good meeting. We thought there was space for us in board development to talk about productivity. It's a term that means different things to different people at different times. And we think there's probably, as we come on to the new committees, which I know is further on in the agenda, think about how do we get commonality of understanding of what we mean by that term and the different kind of levers within it. Links to the performance paper, which Dean talked about a couple of minutes ago. FPC is going to look at mental health performance at its December meeting. We were going to do that in October, but the reason we delayed it was to allow it to go through DHC governance, because we want to be a system group, not piggyback on providers. And so Matthew and his team are doing some work on it through this cycle, and it'll come back in December. The main escalation is around PHC, which Rob touched on in his finance overview, and we think it's an area that, well, FPC's advice to board is we should do some work on it. It's been at FPC, I think, every meeting this calendar year. The hypothesis is there's not a performance issue, there's not a quality issue. There's lots of demand out there, and it's a very expensive service to run in terms of acuity. So the hypothesis is the budget is just underscored this year, but we think it's worthwhile board commissioning a piece of work on that to look at what that means for in-year finances as well as future year finances and MTFP. So that's the main escalation. I think I'll shut up there, Jenny, and happy to take any questions if there are any.
Thank you. Questions or comments for Dan? Okay, Rhiannon, I'm going to go to you next for the quality one, and then Kay, I'll take you for the three that you're doing.
Okay.
Rhiannon.
Yeah. Okay. Thank you. Again, I won't go through it because I think we've covered a lot of this already, but obviously I think the sense was there was some really good, robust conversations in the meeting. I am mindful that we perhaps didn't have some of the people from the wider system in the meeting in the way that we would like, and would absolutely add value for us to be looking at this through much more of that system lens. We did approve or recommend for approval the terms of reference, so that was great. We've already heard from Debbie in terms of the quality report and obviously earlier in relation to the CQC, so I won't say anything about that. We have got as an item later on in the agenda in relation to the patient safety incident response plans being implemented, and we did receive from 2 of the provider organisations, and we will expect to receive from the other organisations in due course. So that's great. I think a real sense that the new approach to patient safety incident it is going to be beneficial in looking at it much more through a system and learning lens. So I think that will be great, but we'll hear about that later. We received an update around medicines optimization. I think we did have a number of areas of concern that we asked for some further work to be done, which will come back to us, namely the prescribing around and the monitoring of the monitoring of valproate prescribing, some concerns around polypharmacy, and obviously the impact on particularly older people and their ability to stay well at home if that isn't right. What else? We received obviously the clinical strategy, which we'd heard in the board development session. Obviously it's still at draft stage, and obviously Paul and his team will be taking that out for further socialisation before that comes back. Obviously we'll come back to the board ultimately in terms of the need to get going with that. And I think there is a question about how all of these things join up, because they're all very important, but how we join everything up, I think, still remains a question for us to sort of grapple with. So I think there was nothing significant for escalation, so I'll leave it there, Jenny. Thank you.
Thank you very much. Any questions for Rhiannon? Okay, I'm then going to come to you then for clinical commissioning for the people and culture and for primary care.
Yeah, so in the case of clinical commissioning, you'll see the report there. I think one of the key things that we were particularly excited was the integrated neighbourhood teams update. And you've seen the papers anyway, because they're on the board papers. And we did stress the fact that leadership development in that area will be key, and just as Rhiannon was saying, the linkage between that and various other areas of work to make sure that that is effective. Lower limb ulceration service review, we heard the report on that and encouraged them to move at pace, because this has been an issue for a long time and we need to be moving on quickly and implementing the changes as quickly as we can. And committees we talked about. I think the key thing, one of the things that came up was when we looked at the corporate risk register, where we were being asked to look at possible mitigations and actions taken, and we wondered if it would be possible for the person responding to the risk to give us some sense of the likelihood of reversing the trend, mitigating the risk, and expected time frame for this, because as we know, some of these are on the risk register for a very long period of time, and we're not getting a sense always how long it's going to take for this to be addressed. So those were the key ones, I think, from clinical commissioning.
Thanks, Kay. Can you just move straight through all of yours, and then I'll pick questions up at the end.
Lisa has given me what she said she would have said here, so I'm just going to read this out to make sure that she'll be happy with what was reported. So these are her comments, and she said, we welcome the communications report outlining the general plans to support the ICS with key transformation outcomes. We asked the team to reframe the next report so that we can clearly see the impact of the various campaigns on the 5 strategic pillars. The links are there, and the team answered our questions well, but the report didn't pull out the alignment clearly enough. And this is obviously something that's going through several of the committees, isn't it? This alignment across. We also heard how the team were working closely with Public Health Dorset and Wessex Research Partnership to optimise our campaigns using behavioural insights in key areas. We welcomed the communication engagements plans for the winter pressures and vaccination programmes. We noted the creativity of the team in working within extremely limited and in some cases non-existent budgets. We also asked them to amend the report slightly next time to give us less narrative and more visual data on specific target audience and outcomes. For example, breadth versus depth of engagement and communication message timeframes. The deep dive into the ICS recruitment strategy was informative. There's some good work underway to address the wider problems affecting recruitment, and the committee looks forward to learning how these activities impact some of the recruitment pinch points in due course. The committee will start to receive the progress updates on people plan and dashboard format from now on, making it easier to monitor performance. And that was all that Lisa wanted to draw to your attention.
Great. So now you can move on to your actual committee.
Yep. In terms of primary care, we approved the minor surgery DES funding, although we did recognise that there were some issues within that. We approved the Dorset delivery plan for recovery access, while noting this is really about extra demand rather than improving access, because we are already seeing more appointments. I think the key thing to bring to the board, though, was a trend which those of us who've been involved with primary care over some time are recognising going forward, which is the number of GP practices which are closing and the increasing difficulty of distributing those patient lists. And this is a critical trend, hence the link to the sustainability of the GP system. But it's not just GPs, it's also dentistry, pharmacy, and there is a real worry that high street healthcare is at risk here, with the number of access points being closed. And if that continues, that's going to become a real major issue for us. So we did ask the exec to have a look and see whether this is something we should put on some kind of potential risk register somewhere, because it's not yet at the critical point for the risk register, but it is emerging, I think, as a real significant issue in primary care. And as Patricia was saying, primary care is the bedrock here. And if it starts to fall over, we've got problems right across the whole system. So with that discussion, I think we felt that we needed to raise that issue with the board to highlight the risks that we are seeing developing at the minute. Thank you.
Thank you very much, Kay. Any questions on either of those three reports for Kay? Okay, thank you.
Jenny, I haven't got a question on those, but could I just raise something about the Finance Committee update?
Yes.
Please, because I just want us to think about whether we are getting the right balance at the committee around, because it's got such a broad remit, and we've obviously got some financial challenges and we've got some performance challenges. So just for us to think really carefully about whether we're getting the balance right in terms of the length of time as discussion and scrutiny on each of those areas, because I'm just conscious of the fact that the majority of issues raised on the report around assurance or escalation, there's only one that really relates to performance when we've got a number of challenges there.
Okay, so let us move on then with that caution there from Patricia, and if I can just ask Dan and Rob to take that in mind. John, you're wanting to come in?
It was just a reminder that we're out of cycle on the risk and assurance committee rather. So
yours is next week, isn't it?
Days, exactly. So
yeah.
That was just the reason.
That's why we haven't got one. Okay. Thank you for that. Okay, so let's move on. This next item is the only item that we have got for decision, and it is the ICB governance arrangements. It has actually been through all of the committees. I think it's been to the system executive group and various places, so it should be familiar. We've also taken it at a development session, but I will hand over to David Freeman to take us through. And then to be clear what you need from us today, David, to get this signed off.
Thanks, Jenny, and hello everybody. So I just wanted to say a few introductory words before passing to Liz, who will give us an overview of the main papers and what we're looking for out of this. As you've just said, Jenny, we've been working on the committee refresh since the summer. Remember the summer? Look outside your window now, you might easily forget. But we started with an exploratory development session in June, and then through various other conversations and discussions, we've been honing in on the agreements and the final proposed arrangements, which brings us to today's recommendations and ask of you. Just to remind ourselves and underscore all of this, our shared ambition throughout this refresh has been to ensure that the ICB governance is properly designed to deliver our collective vision and the goals that we've got for the populations of Dorset. So that is just to really be clear, to ensure that everybody has a chance to live their best life, and that we invest as much more time, effort and resources in early help, prevention, in tackling inequalities, and more broadly, the causes of ill health across our communities. So I think that if you read nothing else, and if you just looked at the focus or the titles of these new committees, you will see that we have started to gear our operating model to do just this. And that's really important. It is a shift away from how our predecessor organisations were required to work to how we are now A, required to work, but B, want to work as well. So Liz will take us through the main highlights, as I said, but before I do that, I just wanted to finish my bit by saying a big thank you to everybody who has challenged, contributed and helped to build this model. I don't think you can underestimate how much thinking, planning and crafting such changes require to get us to this point. And in particular, I want to thank Liz and the corporate governance team for their amazing work in pulling all this together and bringing us to this point. And on that note, I'll pass to Liz, and hopefully she's not blushing or anything as I do that.
Thank you, David. If it's helpful, I just thought I'd run through the key points on the papers, which are in two parts. So we're bringing to the board for approval today the governance handbook amendments following its annual review, and the revised terms of reference and the work plans for the board committees following the committee refresh, which David has just outlined. Before I go into this, I'd like to thank Steph for all her work on the governance handbook, because it's been a really large job and she's coordinated all of that for us. The handbook is a requirement for us under the Constitution, and the board are required to see it annually, which is why it's included in the papers in its entirety, and apologies for the fact how long that's made the papers. We've made some changes over the year, and relevant approvals have been sought for those as we've gone through. So we're not approving anything retrospectively today. The amendments we're bringing today are listed in section 3.1 of the report, and they're also tracked in red in the handbook for you. That's appendix 1. The key changes mostly relate to around the committee refresh and how that will impact on the documents that are contained with it, such as the function decision map, the scheme of reservation and delegation, and the standing financial instructions, all of which will update after we have essentially signed off and approved the committee structure today. We've also made changes in there around including the vice chair role, which we now have in post, updating the reference to associate non-exec role to reflect the current position. And we've also made a couple of small updates to the standards of business conduct policy. There are no items in here that I would want to raise as items of concern for the board. And all of these bring us in line with what we would consider as standard to be in the governance handbook. The governance handbook has not been seen elsewhere, so it is here for approval today. Just noting that some of the updates relating to the committee refresh we will enact after the meeting today if the board are content with that, and we won't bring it back unless there's a feeling that you would like to see it again. That was all on the governance handbook. Jenny, would you like me to just tee up a conversation on the terms of reference as well, and we'll take them both together?
Yes, please. Yes.
So just to reiterate, the terms of reference and the work plans are being brought to the board for approval today. And we've also included the terms of reference on a page and the committee objectives in the pack for your information. For the revisions, there are the revisions to our existing committees, and also the new terms of reference that have been drafted: Prevention, Equity and Outcomes and the Strategic Objectives Committee. And following the discussions at board today, these will go to the inaugural meetings of those two committees in December for further discussion. The terms of reference and work plans that you see have been worked up in conjunction with the committee chairs and the chief officer leads, and have also been reviewed for the existing committees, have all reviewed their revised terms of reference, And as listed in the report, the Clinical Commissioning and Primary Care Commissioning Committees also reviewed the Prevention, Equity and Outcomes Committee and their work plan. Risk and Audit Terms of Reference and Work Plan have been reviewed by the committee chair, but due to the timing of the committee haven't seen those yet, but we're asking the board to approve those today, noting there might be further amendments following the meeting. The Prevention, Equity and Outcomes, we're taking their Terms of Reference and Work Plan to the December meeting. And the Strategic Objectives Committee, their really draft terms of reference are included today. There's some further work to be done with the committee chair and the chief lead, and those will also go to the inaugural meeting in December. I think it's likely we'll see Prevention, Equity and Outcome and Strategic Objectives, Terms of Reference and Work Plan coming back. So we're asking for initial approval today, with noting that there'll be iterations to come. The Terms of Reference and Work Plans have been amended in light of those discussions at the committees, and all of those updates are listed in section 1.7 of the report on page 126. I won't go through them all. Most of them are around standardisation of the wording and to remove duplication, to make the terms of reference much more user-friendly, setting them up with the core purposes and key responsibilities at the beginning and then doing the housekeeping information afterwards. We're also strengthening the committee's role in relation to the ICS core purposes, which we felt was really important when we had the initial discussion. We've updated the memberships to strengthen those around wider system membership of the committees. And there's also been some clarification on terms around members, attendees and invitees, and also a change to the policy to allow one of the chief officers to be represented by their deputy chief officer. So we're asking the board to approve, noting that some may come back following the December committee meeting.
Thank you very much, Liz and David. It's been a significant piece of work over a period of time, because that is because it's really important for how we do the business. So thank you to everybody that's been involved in it, particularly led by Liz and David. I'm going to go to Dan and then Vicky or Graham.
Thanks, Jenny. I just wanted to reiterate the thanks, because it's been a huge piece of work and really helps us think about how the committees provide assurance to the board and what the system purpose is of these committees. I think one of the things that we started seeing, we'll see, is how also the committees work together, not always through the board, because kind of that part of the jigsaw is really important. That really leads me on to my question. I just wanted to check that the People Engagement and Culture Committee, if I've got the name right, will be the lead committee on agency, because we quite often see in the performance reporting and the financial reporting, we overspend on agency against budget and against plan. Of course, it impacts on quality and productivity and performance. But I just wanted to ask a question about where would agency sit. It was Kay's summary from Lisa that triggered the question, but I thought I'd hold it to this part of the agenda. And so it's just clarification on the agency risk and which subcommittee would be the primary lead on it.
Okay, thank you, Dan. I'll go to Civic Centre Room, Vicky or Graham, and then we'll pick up both questions.
Thanks, Jane. It's probably both of us, but it's the long-running issue about nomenclature and areas as ever. If I go to paragraph 6.1.2 and 6.1.3, it hasn't changed. So I'm commenting on the substantive, the original substantive document, but it talks about the BCP area, brackets east, and the Dorset Council area, brackets west. Then lists the primary care networks that are in each, but it's wrong, because it talks about some that are in the east, like the one around Swanage and the one around Burwood, but they're not in the BCP area. So there's a real mismatch again in the nomenclature between, and actually east and west doesn't work, because if you look at Burwood, it's quite a long way to the east of Dorset, but it's not in the BCP area. So east and west as a simple moniker just doesn't work. And I just think we need to clarify that. Then we need to correct there aren't 18 PCNs, sorry, there aren't 13 in the east if the east is defined as BCP, because the one in Burwood, the one in Swanage are not in BCP. So there's a whole set in there just to sort out and resolve, I think. Happy to do that offline, but we're still not getting it right in terms of the nomenclature. And we talked about, do we have a pan-Dorset and Dorset Council and BCP Council areas? We need to get that right.
Thank you, Drew.
No, it's the issue for me is around, you know, for the public, if they looked at the map in 6.1.3 and were told that half of these were in the east, they are in the east of the county, but they don't represent the administrative coterminous boundaries of BCP.
So I think it's important that we get that right. So let's take it offline because we're not going to be able to sort that now.
Absolutely.
But it is important we get it right. And Spencer, you've also got your hand up.
Thank you very much, Chair. Yeah, I was going to say something very similar, so I won't dwell on that point. But it's a matter of consistency and clarity for those people that get to read this sort of thing. I think that's really important. But I support the broad thrust of this. A huge piece of work been done. Really good stuff. I also like what I wanted to emphasise is that link between the ICP, the ICS and the health and wellbeing boards, because we changed our constitution to bring our board much closer to what we're trying to achieve here, and I think that's a positive. So I just wanted to comment that we're broadly supportive of this, but I do think some clarity needs to be put into the wording around what East and West looks like. Thank you.
Thank you very much. So a similar point there. Liz and David, if just for you to think about how we pick those two things up, because we do need to make sure those are amended and correct. And then do you want to respond to Dan's question also about agency spend?
Yeah, shall I come in on that? Actually, I think John Soper in the room had his hand up. I don't know if yeah, there he is. They're waving again. So do you want to go to John first, and then we can follow up?
Apologies, I can't see John's hand up on mine. Let me.
Thank you.
Oh, you're in the room. That's why. Sorry, John. Yeah. Go on.
And it's probably just a small point actually. It's around the membership around the Prevention, Equity and Outcomes Committee. Given that its responsibilities are about things like social and economic development and wider inequalities and so on, I was wondering whether that's the membership of that committee. I note that it's got the option to include other people who aren't members, but whether a bit more inclusively, it's probably the one, in my opinion anyway, of these groups that actually has the most diverse set of things to look at. And I think to have at least named extras would be useful, and certainly would recommend that the economic and business community and the academic networks are represented, as well as the VCS.
Thanks, John. We had a similar discussion this morning as non-executives, actually. So, David, do you want to go first?
Yeah, if I could, and I'll be swift if I can. So the agency spend bit, Dan, that will sit within the productivity committee because it's currently sitting as one of our productivity targets. So it probably hasn't made it into the scope because it's emerged as a separate stream of work of the productivity stuff, but it will report through that committee into board. The naming and clarity, yeah, I mean we're moving ever better away from the use of East and West, and apologies to colleagues that's still lingering a little bit. We will double check in 6.12 and 6.1.3 as well, because the number of PCNs for the BCP footprint and Dorset Council footprint is correct. So it's not showing properly on there. So we'll clarify that for colleagues, and apologies that we didn't spot that beforehand. And John, to your point on membership, yeah, there is a job to do here, some reflection, because that committee's membership could be massive given its scope. You'll note from the work programme that we've put in there quite a few briefing items to try and get the committee to orientate around what the new responsibilities are, because there are new things in there. And I'm thinking of the sustainability, anchor institutions, social economic good. What does that actually mean? What does that mean for the work we need to do? And what does that mean for the work we need to pay attention to? And also thinking if we're overseeing that or trying to assure that is that work happening somewhere else where we could take assurance from. So the Integrated Care Partnership is also covering a similar agenda, but its work programme might not be as focused on that. So definitely, John, really great suggestion, and we do need to keep a very close eye on it, and we will review to make sure it's as robust as possible.
Great. Well, thank you very much for that. And through you, David and Liz, can you thank the rest of the team as well that's been very involved in getting us to where we are today. And we look.
Dawn.
Patricia.
Dawn's got a hand up.
Sorry, I really can't see the room, so it's helpful to let me know. Dawn.
Thank you, Jenny. I just wanted to build on the agency point, and as David has expressed, this will sit within productivity and performance. However, while some of the solutions to the productivity and performance, the system solutions to people systems, for example, around collaborative bank, a culture of well-being to support retention, that will of course sit within people and culture. So there'll be referrals across, Jenny.
That's really helpful. Thank you very much for that, Dawn. Okay, let's move on. We have now got a number of items for noting and discussion. We're going to start with something that's been mentioned earlier, PSERF, the Patient Safety Incident Response Framework. And Debbie, I think you're going to take us through that.
Yeah, thank you. Very quickly, so the new Patient Safety Incident Response Framework, as is said in the paper, was something that's a national requirement for across the whole of the NHS, needed to be implemented from autumn 2023. We've been working on this as a system with the Task and Finish Group for the last 12 to 18 months. So the first two, there's a requirement for ICBs to actually sign off provider PSERF plans, that's the acronym, and the first two from Dorset Healthcare and SWAS, the ambulance service, came to Quality and Safety Committee last time for us to review, discuss and then approve. I'm pleased to say that we did approve them. We thought they were both very clear, well-written reports. And we have confirmation that the plans from UHD and Dorset County Hospital are coming to the Quality and Safety Committee in December. So we're well on track. We've approved these two plans. We will review the last two, as I say, in December and bring those to the board after that. So, but they're for noting today. Thank you.
Thank you very much. Any burning questions? Okay, if not, I'm going to move us on to the integrated neighbourhood teams, next steps and plans, because I've seen that Katrina Percy has joined us. Welcome, Katrina, and hello. David, did you want to start first, or are we going straight to Katrina?
Yeah, I'll lead off if that's all right. On behalf of Matthew Forbes and I, who we're all named against this item, I've got a hat trick of items coming up for the next three things. So a bit like Kay was saying earlier, you might get bored of my voice, but I like to think this one is like Harry Kane's goal. And if you're familiar with football, he's got a hat trick at the weekend, and one of them he scored from the halfway line. And I think the vision and execution of that was awesome and very exciting. So even non-footballing fans, it might have caught their eye as well. So this for me is that one.
That's a Beckham goal, isn't it?
Yeah, it is. So this is where we got. So this is really exciting. So we wanted to bring this today. In core terms, to seek your input and support this and your support for this delivery of this very important transformation programme, because it's going to change fundamentally the way we support our local people and our communities in order to help them thrive. As I said, I will set the scene briefly, but as you've noted, Jenny, we've got Katrina Percy here from the National Association for Primary Care, the NAPC. Katrina led the team working with us to listen and co-design the model with our partners across the whole of Dorset, and you'll see that described in your papers. And we thought it would be really helpful if we could hear from Katrina about the work and how it fits locally, but also it's a bit of context around regionally and nationally, because this is an important area of work for us. So as you know, we've got a shared strategic priority to make a fundamental shift in the model of care that we deliver out of hospital. And we want to deliver outstanding personal care that is, as far as possible, anticipatory care rather than just reactive, which means building effective teams with all the skills and capabilities around that, but are able to adapt and flex to the local needs of local populations. And that's why we are focusing on this kind of neighbourhood level, this lower number of population level, but within the communities that we serve. And we see it as a key approach to improving population health and outcomes as part of our five-year forward plan, 5 pillars. And of course, within all of that, there's a great opportunity to improve productivity and the satisfaction of care provided to our local populations and the greater interprofessional collaboration. And if we weren't already convinced by that as being the goal, as we were producing, as our recommendations were being published that NAPC helped us with, the NHS Confederation published a report called Unlocking the Power of Health Beyond the Hospital. And that was published in September this year, which demonstrates that continuous funding of acute services is failing our populations. It's not meeting the needs. It's not keeping up with the demand and the complexity. And it also demonstrates, with some really good methodology that we're lifting to bring into our system, it demonstrates that by investing more in community and GP care, we can actually reduce non-elective pressures in hospitals by about 15%, and we can release up to £30 million of savings and health value back to the local communities. And crucially, the work they did on their model is not as ambitious and as broad as our plan here. So if anything, those potential savings and opportunities are underestimated for Dorset. And also, I think on top of that, we need to, it's worth noting that our spend on community services in Dorset is 6% of our total budget, whereas the Confederation figures based on the benefits you can get worked on a national average spend of 9%. So we've got some way to go and the great opportunity that sits within that. So earlier in the summer, we asked NAPC, we invited NAPC to come with us. It was a joint commission between the ICB, the Dorset Healthcare and the GP Alliance to come in and help us build the first version of an integrated neighbourhood and community care framework that was drawn from a consensus of people across the system, but also crucially described how the model might work and how we get there. And that's the kind of product that's sitting in your pack at the moment. So I'll pause there briefly to see if Matthew and or Forbes want to add anything before we pass to Katrina, who can take us through some of the highlights.
Thank you. Forbes, Matthew?
Really just endorse all that David has said. There's a lot of enthusiasm, I can say, within colleagues for this piece of work. So I'm very keen that we get your support to progress it with some pace, actually. We've heard about the challenges that exist within general practice. And as many of you have seen, we produced our resilience support report. I think there's huge alignment here between this piece of work, the GP resilience work, and the place-based working. And I would like to see them progress at pace together. So we haven't got duplication of effort, but equally one arm of these three things is not limited because one is moving a bit more slowly. And it has to be a whole system approach. So while there's, health are key players, local authority are equally key players in this. So I think we do need to do this as one. What further encourages me is that we've just asked for expressions of interest from our primary care network colleagues to support the progress with the GP resilience report. We've had a lot of support from colleagues to do that. So they do see it as a way forward. They certainly cannot do it all on their own, so it requires support. But David, Matthew, Kate and myself have been in conversations about that, and with your support, I think we can take it forward, and so it is encouraging, yes.
Thank you. And Katrina, before I go to questions, because there are hands are starting to go up, did you want to add anything, or are you happy to respond to questions?
Let me just give you a very quick summary, because one of the privileges I have working with NAPC is to work with different systems around the country in this sort of space. And as David said at the beginning there, the plan that Dorset have come to, and as you'll see from the pack, this has been a hugely broad engagement exercise to build consensus about the scale of ambition, as well as some of the flesh around the details on the care model. It's been an absolute pleasure talking to colleagues through the process. And I think what I see compared with other systems nationally is whilst there have been, and it's very clear in the pack, there are areas of difference still, as you would expect, difference of opinions, which we've been able to pull out, but that broad level of ambition to do the right thing for both the people who live in Dorset, but also the workforce has come really shining through. And I've called it bravery, and it's been knocked down a few times. This isn't brave, this is just doing the right thing. But what I see is the opportunity in Dorset that people want to take the steps that are going to be all encompassing. So just a couple of highlights. As David said, this is fed both from national, it's actually international best practice as well as national best practice. I think the big difference is when you read Claire Fuller's stock take, there are individual elements of good practice across the country, and many of them are in Dorset. We saw them while we were there. The big difference in this plan is this is an entire system. How do you move the entire system of Dorset from the fragmented, siloed, layered model that we currently have into an integrated model that better meet the need of the community? Three big movements forward and a couple of points I want to put out. So the first is that the whole system will move to integrating general practice, the PCN workforce community, community-based mental health teams around local communities. And what I found a massive learning point for me personally, actually, is how local people need to go in a county like Dorset, because there are populations of 4,000 with a real sense of community around villages in some of the middle and north parts of Dorset. And what the consensus was that you will build teams that are appropriate to that community with the right skills in them, alongside somewhere like Weymouth with a 55,000 population community hospital, and you're going to build a team that work for the people of Weymouth as well at sort of 55,000. So it wasn't a classic public sector, let's draw some lines on a map, everything must come to 30 to 50,000. This really became a genuine piece of thinking around community and community up. So consensus that we do that everywhere. That could be deck chair moving, I think, is the real risk in this. And what I know that the leadership team, both clinical and non-managerial leadership team in Dorset understand, is that it's the investment in those teams and their ways of working and how they work with local people, how they work with partner organisations and leadership development that's actually critical to success, not getting a giant workforce plan and saying, how do we cut it into these 50 different teams based around communities? So there's that point. Then, of course, the in-depth work that's going to go on.
Sorry, Katrina.
Yeah.
I'm getting some background noise. I don't know
are
if other
you?
people
Sorry.
have, but...
It's not from you, Katrina. Somebody's not on mute.
Okay,
Yeah,
sorry. I am in
some
a
talking
public building, so it might be
Oh,
made
right.
worse by me.
It may well be you then. But
Anyway,
carry on.
So point 2 is the wider working with local authority VCSE partners. David's outlined that, and of course, very importantly, and Siobhan was superb on this. How do we make a real cultural shift with the specialist and acute sector? In reach, I think, Siobhan, you called it. How do we shift the entire culture from pushing outward of acutes to the out of hospital element needing to enrich for specialist support, and that being a seamless pathway? All of the trick, though, is in the how we do this, because I think all of us in this room can talk about it. There's a sort of 24-point sort of pretty detailed plan that we worked up with your teams that sits there in the pack. But a lot of it, as I said, revolves around investing in those local teams and their development, giving them the headspace to do things differently. So that's a sort of high-level summary. I think it's very exciting for Dorset, is what I would say. As I said, I work all around the country, and I think I see this ambition across. We've talked frontline teams through to the senior teams. There is this cross consensus, but also acknowledgement of difference that I think is critical in the opportunity to move forward.
Thank you, Katrina. It's really helpful to set out how you see that happening, actually. Matthew, you put your hand up. I don't know if you wanted to say something before I go to the other hands, because I know you were part of the group developing.
Thanks, Jenny. I mean, maybe we could hear the contribution from others and then I could come in at the end.
You're on mute.
Jenny, you're on mute.
Jenny, you're on mute.
I don't know how I went back on mute. Sorry, I was just saying I'm going to take everybody. We are over time, but it's really important that we get into discussion on this, because it's quite an important piece of work for the direction of travel and the things that we want to do. So I'm going to start with Jonathan, then Rhiannon, then Patricia, then Vicky or Graham, I'm not sure which one, and then Zoe.
Thanks. So obviously fully support this. I think I just want to build on Forbes's point. There's something for me around presentational consolidation of this concept. So I mean, I just look at the next item, which is right care, right person. That could be right care, right person, right place. And we've also got papers, or had papers about pharmacy first and things like that. It would be good if they sort of stop presenting themselves as sort of individual projects, and we kind of somehow presented them under one banner as aspects, or we just said, actually no, these are all part or parcel of the same strategic policy, instead of maybe reporting on them separately. I think there's something about the presentation of that. There's also something about saying, actually, well, that's just part of this, and how we tactically put all this together and present it. But I mean, otherwise, obviously really supportive of this.
Rhiannon?
Yeah, thank you. Yeah, I think this is fabulous, and to me this is what the ICB is all about, and I really would like to be hearing more about these kinds of things as we progress through with the direction of the ICB's focus to get more of the balance. I actually really like the way it's been presented in terms of the slide deck as well. So just to give that feedback, I think it's really easy on the eye to interpret and understand. I'm glad, Katrina, you referenced international best practice, because I'm sort of familiar with the younger Ping. I can never quite pronounce that, even though I've got a sister living in Sweden. And my question was going to be, particularly in terms of, so I saw the point about we don't want PIDs, we don't want, you know, some of the old-fashioned ways of perhaps, or the current ways, not necessarily old-fashioned, but current ways of how we look at progress. But we do need to have measurement of the impact. And so is it worth having a look to our international partners that have been at this for many, many years and have some excellent outcomes? So at that point. And my final point, I think speaks a bit to what Jonathan said. It's that how do we really sort of stop things from looking like separate silo things? I'm not suggesting they are in reality, but you know, Paul will be leading on through, or is leading through, the clinical strategy. So how is the clinical strategy going to tie into this? Because that's all about prevention to palliation, and how does that then weave into these important sort of community-based assets that are going to really help us be where we need to be. So thank you, everybody. I think it reads really well, but it's the how, isn't it, as ever. Thank you.
Patricia.
So thanks, Katrina, and also a big thank you to you and Andy, because I think they've done a brilliant job on galvanising our teams with common purpose, but also giving them some constructive challenge and wanting them and supporting them to be really ambitious in their thinking. And I think that's why we've got to where we are now. I think that the key pieces of work that we're talking about are all aligned in terms of what they need to deliver and are different parts of the whole. And I think we probably need to think about how we articulate that. It is really difficult keeping a handle on all of this stuff because it is very complex, but you'll remember when we looked at the clinical strategy a few weeks ago, there'd been a lot of work in trying to make sure that reflected the other pieces of work that are happening across the system that are intimately connected to it, and all the delivery timeframes were aligned. So I think we are there, but maybe we need to think about describing that differently. I think we need to think really carefully when we move into implementation, because we're doing it in 2 phases, and also that culture change takes time. So for me, this is not a quick fix. This is a 2 to 3 year programme of developing all the neighbourhoods and getting them running the way that the community will benefit from. I think we need to think really carefully about how we design the front end, which is the health element, and not in such a way that then we can't incorporate VCSE and local authority without them coming into a model that is already delivering in a certain way. So we need to think really carefully about that. And the OD support and structure that needs to be wrapped around this is huge, because changing mindsets, thinking, How do you work with one team, single operational policy, single leadership, even though you might be employed by different organisations? I wouldn't want us to underestimate just how complicated this is. But I do think it delivers on a number of things. I think it is ambitious and it goes way beyond what is in the Confederation report and what the potential return on investment should be. So we need to think about that with some pride, actually, once we start to deliver on it, because this is very ambitious. It could be one of a number of streams that support the sustainability of our primary care function. So, you know, it's important that we define very quickly where those neighbourhoods are and start to run the first level of development around the 4 areas that we've agreed. It delivers on care closer to home for our communities, and that is one of the key things that came out of our 100 Voices work. Local really matters, and how do we prevent people from coming to hospital unnecessarily, especially if they're old, because hospital is not a safe place for elderly people. They get hospital-acquired infections and they decompensate. It's the signal for us moving more into the prevention and early help space, and our medium-term financial plan needs to reflect that change and shift in our investment portfolio, and also think about what we do about double running while we're moving into a different way of operating. And I think it's got the potential to reduce the overall cost of social care. And so we need to really think about some of those things in line with what Rhiannon said. What are the outcomes that we're trying to achieve, and how are we going to evidence that those outcomes have been delivered, and concentrate less on process in the impact on our communities and our overall spend on health and social care being in the right place. Thanks, Patricia. Vicky or Graham?
It is me this time, Jenny. This is a really good document, and it's good to see how many people have been involved with it and the listening side of it. I am going to bring up the things that I brought up last time when we talked about this when we were in person, and that was the references to children. This is really a paper about older people, which is absolutely fine and dandy. However, there's a picture of a children's centre in all of the illustrations, and that gives the impression that it's about the wider community, and it clearly isn't. So if it isn't about children, there is a reference in one of the 5 pillars about children's obesity. That seems irrelevant, and the picture should probably come out and make it really clear this is about older people. And let's have a similar piece of work around how we support children in the community, because if we are including children, we need to be looking at speech and language, play therapy, and all of those things which are not covered. The second point is around the neighbourhoods themselves. Obviously, we've been given the demonstration for Weymouth, but within the document, there isn't a breakdown of what those neighbourhoods are going to be, so that the public can actually understand that. So I don't know how many there are going to be, where they will include, where people will gravitate towards. I think that would be useful. And then the other point on towards the end of the document, what page did we say it was on? 500?
Oh, 534.
530, page 534. Leadership and governance during the transition. There's nobody there from the local authorities. Just wondering whether the corporate directors, people like Gillian Kay and the Teresa, I think it is in Dorset, where you've got your GP leads and others. If there isn't any local authority leadership there, then you're missing a trick in terms of the real place-based leaders. So I don't know whether that's something that has been considered. Thanks.
Thanks very much, Vicky. And Zoe.
Hi, yeah, just following on from what Katrina said and now what Vicky said as well. I think, this is all obviously very much about medical support, which I totally accept. However, there are other issues for recovery and prevention, including sort of mental health as a big one, financial issues, life issues, and place and local communities. So it's and obviously if we're doing very local communities, but also the broader communities. And I see very clearly with my hat on today as the interim chair of the BCSA board and assembly, I feel this is where these pieces of work need to really tie in, because of the support as the third sector and the charity sector can actually give to you to give to our residents to actually help them get through the issues that have actually got them to that place in the first place. And I know I keep banging on about this at every meeting I go to, but with my other hat on as Chief Executive and Advice, you know, we can see how the mental impact is happening on people that are attending GPs and going to A&E because they don't know where else to go, but actually that isn't their problem. So I think there's got to be a lot more time and effort and work to actually stop them actually coming to you in the first place. Thank you.
Okay, there's a huge amount of comments and thoughts and issues to be considered as part of the next stage. So I'm not going to ask the team to respond to those now, but just to note them and take them forward. There is one thing though that I do want, and it's probably Matthew to come back to, or David, which is the thing about consolidation, because we have got lots of different activities happening. How do we make sure that this is all one pie and not lots of different pies sitting on the table? So Matthew, do you want to come back on that?
Yeah, thanks, Jenny, and there's a couple of other comments I want to make as well. So I guess just leading on from the discussion, there's a phrase which I'm sure kind of people are familiar with about not making the perfect become the enemy of the good, or doing something that's better. And I would say what we've got in front of us today is something which is a really exciting proposal to do something good and innovative in Dorset that will be right at the cutting edge of this thinking. And I believe very strongly we've got the ability and opportunity to do it. It isn't perfect, and this is a journey that will never be finished, and it's something that we have to keep walking to build the layers of. In terms of what we've got in front of us, we've got two elements really. We've got a kind of a vision of out of hospital care, and then we've got a proposal about how we do it. And I think what we're seeking today really is comments, endorsement, the start of a conversation on the vision of out of hospital care. We then need to work up how we do it. And what we are intending to do is to bring a proposal through to SEG, the System Executive Group, which will then come through to this board, which outlines next steps about getting this going. And we should be in no doubt that this is an ambitious programme of work, and we will need to back that with resource in terms of time and money if we want the programme to succeed. And what we're proposing doing is linking the work to two places which I think are really important within the system. One is for this to sit under the provider collaborative, which really addresses Siobhan's point about how we get acute engagement right from the beginning of this work. But the second place where this will have a link is through to the place-based partnerships. And as those evolve, what that really means is that our local authority colleagues are also in a leadership role about this, and will be able to lead and support us from health, bringing in the VCSE and those other bits of community infrastructure where the local authority, quite frankly, has more expertise than the NHS. And I think that links to Graham's earlier comments about the importance of getting our language clear around those places and the place-based partnerships in the local authority area. So that's what we want to do next. And Jenny, in terms of just keeping it all together, you know, I think that's where the senior leadership comes in, because unfortunately we're not in an easy environment where we can just put everything in one pot. We need to keep looking at the links. The difference between this and something like Right Care, Right Place is Right Care, Right Place is a national agenda that's being, you know, foisted on us and is about a very specific change. We'll discuss that in a few minutes. This is something that we are generating ourselves, and for me it's really the key to how are we going to deliver those ambitions that we've been talking about in this board, because the kind of fundamental purpose that we need to return to at each one of the meetings about this work is for our 5 pillars, which are our ambitions for population health. How is this meeting, how is this work helping us to achieve those 5 pillars and make a difference, whether that's for the population of Boscombe or whether it's for the population of Portland? So I'm really excited, and I think the conversation that will take place in SEG and come back here in the future is going to be very important.
Yeah, and I think you can see by the level of engagement that everybody's likewise excited. So and we want this to work. So that's really helpful. Yes, please bring it back via SEG at the appropriate moment. Can I just add one additional thing, which was Louise's comment from Healthwatch, who's saying that she's keen to see how local people are going to get involved. So in addition to the wider pieces that you set out, can we also think about that? So Katrina, can I thank you and Forbes and Matthew and David and everybody else that's been involved in getting this here. You can see that people are really excited about it. I echo what Rhiannon said. This is an example of system working and how we can actually start making a difference. So that's why people are really engaged and interested in how we make this go forward. So thank you very much. Apologies, just because of time, I can't allow you to come back on all of the comments that I've made, but please take those forward. Thank you very much. So bye. Thanks very much. Have a good day. Anita, I think you're here, and we're going to go back on the agenda to the health inequalities update.
Anita, should I just say a couple of things just at the beginning? So thank you, Anita. Yes, so and Anita, for those of you who don't know, I'll get her to introduce herself, but she's a really valuable part of my team who's come in really to sort of inject some steroid into our approach around health inequalities and talk through the paper. And I guess just reflecting conversations before, I guess this shouldn't be seen as a separate piece of work. I think this should be seen as a different lens that we need to apply to the pieces of work that we are doing, whether they being out in the community or whether they be around restoration of performance and efficiency within our system. So I'd ask people to see it from that context rather than driving off in another parallel road or a pie or whichever analogy we bring into it. And I hope for what you get in the paper are really 4 things. One is a recognition of the prioritisation that we're putting around health inequalities, not only because it's mandated to us as integrated care systems and boards, but also because there is a recognition throughout our system of the importance. Secondly, that the description of the governance that we need to wrap around this in order to make sure that we've got the proper oversight and the proper emphasis around it. Thirdly, Anita talks through the methodology that we would use around identifying those key areas that we need to focus on and the interventions or the work that we need to do in those spaces. And then fourthly, the starting of a plan coming together and the resourcing that we are going to put behind it so that we have a team that can enable that health inequalities lens to be applied to all the ways that we are interacting with our populations. So Anita, I'll hand over to you. And what we're really looking for is support for the approach that we are describing within this paper. So thank you, Anita.
Thanks very much, Paul. That very helpfully covers the first part of the update I was going to give. Colleagues will see a lot of detail in the paper, not proposing to take you through all of that detail. But what the paper does set out is that there are, as you'll know, a lot of wide-reaching asks around health inequalities and the wider prevention agenda for ICBs and for ICSs, both in terms of what's in the Health and Social Care Act, NHS planning guidance, in the core 20+5 frame that NHS England has developed, and then wider things coming out of the NHS long-term plan and other policy arenas such as the major condition strategy. So a whole range of overlapping and interrelated asks. In addition, of course, NHS Dorset has taken a real focus on addressing variation in health outcomes, and it's absolutely dyed in the wool of our joint forward plan. And that approach that Paul mentioned is on the back of that, really. We recognise that if we do health inequalities in a corner, it'll be a small programme and nowhere near a scale that needed to require to get to make a huge difference to those variations in health outcomes the paper picks up. The fact that people in Dorset, some parts of Dorset, are dying almost a decade earlier than others and living much more of their lives in poor health. And that means some people will never reach pension age and draw their pensions because they die of conditions that are wholly preventable. So our approach in Dorset has been for some time now to have a whole systems approach. In addition to the refreshed governance for the ICB that I know David talked about earlier, which is fantastic because it brings together all the programs of work that I lead on, which I'm very happy about, makes life easier, but actually all those things that contribute to systematically addressing poorer health outcomes and the reason why some people don't do as well as others in life in general. In fact, we have a health inequalities group across the system, which has brought together executive leads and a subgroup of SEC to really think about what they can do together to address health inequalities. What we've been doing recently is strengthening the approach that we're going to take in health inequalities group, updating our terms of reference and bringing in new partners. So in addition to health and social care leads and public health, we'll now have voluntary sector represented in that group and bring in academia, knowing that we can draw on those rare skills that we'll need to make sure that what we're doing in the health inequalities programme is at the scale need to make a difference and draws on the evidence base and has the best chance of driving success by embedding it across our programmes in an appropriate way. So there's more detail on that in the paper. We have had a look at where we are now in respect of health inequalities, and we know that there's some really good work being happening and there's much to do. There has been a focus on workforce development, starting with work on health literacy and developing some tools and resources on our ICB, on our ICS website. Our workforce development colleagues in the ICB, in their leadership role for workforce development across the system, have brought in some really exciting programmes to do that cultural change piece, which I know has been spoken about earlier in this meeting, as important to change how we deliver at scale and pace. So leading on health equity programmes being rolled out across to really make sure that people have got those leadership skills to bed health equity into our programmes, alongside some work led by Professor Muir Gray on value-based improvements. So really looking at that economic lens about how we can shift the resources and understand what our book buys in terms of variation health outcomes and why it's important from an economic perspective to embed that in all of our work. So building on that, next steps are to recognise that we've put in place those leadership building blocks. We've got new clinical lead role agreed. We've got that governance in place, both in the ICB and the system. And we've got it hardwired into our strategic plans across both the ICB and the system, which gives us a great platform to trampoline off with those steroids that Paul mentioned, even higher, to start to motor on that. So the agreement is we'll have a subgroup of our health inequalities group to develop an integrated strategic plan for the ICS, building together all of our actions using those models we put in the paper to make sure that not only are we drawing on our individual organisation strengths and opportunities, but drawing in things that address those barriers, those longer term determinants of health that really get in the way of people having good outcomes, but which we haven't systematically addressed either in Dorset or nationally before, alongside improving the quality of our healthcare services. So we know those things will have different impacts over time, and our cross-system plan will be a smart plan that recognises different impacts over time, but recognising if we don't start now on that wider work, we'll never start it, but we can build in the benefits and benefits realisation over time. That work started with a draft mock-up really of a plan that tracks the benefits over time or expects inputs over time through a logic model, and we'll look to draw on academia as well to build in an integrated delivery plan. So what we should see by Christmas is a new operational group suit set up that's agreed an integrated delivery plan, at least the outlines of one, and that we're starting to use the ICB resources for health inequalities, which have been agreed to align to our strategic delivery plans across the system. So we're starting to use test and learn approaches, understanding what we've got in place already, understand how we can hardwire into existing programmes action on variation, and how we can use that additional resource as a test and learn approach really. So we don't know about what works, how can we rapidly develop our knowledge about what works, how can we rapidly do change programmes so they're embedding what works in, such that anything that we're doing through the programme is really with a view to hardwiring that in through other programmes that naturally lead on those things and not developing a parallel work stream, and things will be taken forward depending on their ability to demonstrate benefit and the opportunity costs, such that they are better than the other alternative we might have in place now. So at the end of the programme, we will have health and action, health inequalities embedded in all that we do. Our staff will be able to talk about it, so our communications plan will be important as part of that, understand their role in it, be able to act on their role in it, and our organisational plans and strategies have variation really just dyed into the wool, stitched into everything that they're doing. So those next steps that you'll see are that integrated plan, further workforce development, communications and what we're doing so everybody's know their role in it, and pulling out some of those key programme areas and conversations across all of our work streams to understand what the inputs are from those work streams and how we, as a health inequalities programme, can support and enable delivery on those. I know you're like short on time, so it's quite a canter through some of the headlines of the paper, but happy to take any questions.
Thank you very much, Anita and Paul. So I'm not going to go to questions. So I'm going to ask one question, which is there anybody that does not support the approach? Okay, so so you've got support from the board as a whole. If there are specific questions that individuals have that you would like some answers to, just to understand a bit more, can I ask you to put it to Paul and Anita for those to be answered outside of the meeting? And Anita, we look forward to the timescales that you've set out, particularly by Christmas, to have that plan in place. And of course, we'll come back to it then. So thank you very much. And good luck with the piece of work. This is obviously really important, the health inequalities piece, particularly for addressing the health expectancy gaps that we have within our Dorset area. So thank you. Okay, so I'm going to move us on then to right care, right person implementation. David.
Yeah, thank you. So I've got two items, and the second one of those can be super quick. So if I can, with your forbearance, pinch a couple of minutes from that for this item as well. I think I saw that Gavin had arrived. There's a slight flurry of concern earlier on that he might not be able to make it because of operational pressures.
I think he's here.
Yeah, I can see his name in the list. Hi, Gavin.
I'll come to. I made it.
Well done, Gavin. I'll come to you in just a moment. So, colleagues, I've quick apology for colleagues, those who sit on the Integrated Care Partnership Board, because you will have heard us go through this just a couple of days ago, actually. And I also recognise there's quite a bit of detail provided in the pack, but I did want to take the opportunity to help set the scene and the context for this paper being here today. There is a clear ask in the paper around the National Partnership Agreement, asking us to sign up to that. But we've also brought this paper to the board because of the local significance and the nationally high-profile nature of this issue. Board members will want to be assured that we have plans in place to address the needs, and in return, it would really help our work to have the sponsorship of the board to be able to deliver this work at pace. I appreciate that some of you will be familiar with the Right Care, Right Person programme. As Matthew trailed earlier, it has come down through a national channels, but I think it's worth reminding ourselves of what is at the heart of this work. Sort of right now, yesterday, today, tomorrow, police officers are routinely being called to support people in mental health crisis or children in care who may have absconded for a few hours. They are called even when it is clear there is no immediate risk of harm or risk of a crime being committed. But when a police officer attends such calls, they have a duty to ensure the safe handover of those individuals to other agencies, but often can't do that. So they could be tied up with some of those individuals for several hours. In some parts of the country, not our part, but on the national calls and regional calls I've been on, this kind of support provided by police officers is often dubbed as the auxiliary mental health crisis service for the NHS, such as the demand and the reliance on this informal service being offered. So, and I think all of us here would recognise this is a horrible dilemma of feeling a duty to support somebody in need of something when you've attended an incident, but doing so at the cost of not attending to your statutory duties. And in this case, this is a potential crime or harm happening elsewhere. So this has been happening up and down the country. This is not unique to Dorset. And this programme emerged in Humberside to try and tackle the issues. And it seems to have a really positive way forward. And it's subsequently been adopted nationally, as described in the paper. Some of the police forces up and down the country, and for example, the Met, you will have seen this in the national headlines, have moved immediately to implement this model. They set a cliff edge deadline of September just gone, that is, by which they were going to remove all the support for these types of calls and cases. And this deadline was set regardless of whether the London system was ready to fill in for that support. I'm not sure that is the best approach, but I can certainly see the moral imperative for the police forces up and down the country to focus stretched resources on incidents of crime or danger to life rather than these types of call-outs. So I think such moves by others amplify how lucky we are in Dorset, that Dorset Police have committed from the outset to taking a different approach with us, one that's about true partnership and about ensuring and giving time for all the agencies to work together carefully but swiftly to implement these new models. And it's worth underscoring to Gavin and colleagues how much we appreciate and value this approach to dealing with this tricky issue. So the plan in your paper described today has been jointly developed by system partners and reflects how we can work together to make these positive changes. When we discussed this at the ICP on Tuesday, there was a real desire to move faster with delivering some of the targets that are set out in the plan. So we've started working through that, but clearly we haven't been able to do that in time for today's papers. So it's not reflected here. What you're seeing is the previous iteration. But on all that, with that in mind, I've probably said enough to set this up. Let me pass to Gavin. If there's anything you wanted to add, Gavin, in terms of key points around this, and then we can sort of take comments and questions.
Thank you, David. You've added everything from the ICP. I'm happy to take any questions. I think the information in the paper is relevant. There's nothing more I can add because I know you're short on time.
Thank you very much, David and Gavin. This did actually get a full testing and a list of questions at the ICP on Tuesday. So, I think what I want to do, unless there's any burning issues, I'll come to Matthew first, but unless there's any burning issues, I just want to ask a similar question about whether or not we are happy to support the direction of travel and the plans that are in place. Matthew.
Yeah, thanks, Jenny. Hi, Gavin. Really nice to meet you this morning. I'm sorry we haven't met before, but I know you work really closely with Chris Dominy and other colleagues. I'm the Chief Executive of Dorset Healthcare in Dorset County. So I guess just a couple of really quick points. So one is, I think we are extremely fortunate in the local leadership that we've got around this, both in health, but really I want to thank our police colleagues for the leadership that they are showing in this area. And I know Amanda Pearson is, keeping very close to this and wants there to be a good positive transition from one way of operating to another. I think the second point I'd like to make is, at a very broad level, this has got to be the right thing for the people involved as well. So a mental health crisis, is not something that the criminal and justice system should be responding to. It's something that we should be responding to as part of healthcare. But the third point I'd like to make is, I think we do need to recognise the reality of where we are and the sort of historic gap, which I would say is associated with the whole issue of parity of esteem. So we are not equipped, we are not set up to deal with a mental health crisis in the way that we need to at the moment. And that's really the work that we need to do in the Dorset system. So I would endorse the direction of travel here. And I think we should be signing up nationally to this. But I also want to express a concern here today that at the moment we don't have the right infrastructure in place from a health point of view to respond. And looking at the timeline of the work proposed today, I'd like to suggest, and perhaps this needs to be considered outside of the meeting, that we try and bring a clear plan back by the end of January, which is absolutely clear on the gaps and how they're going to be met going forwards, because I think this is going to be quite challenging in terms of ways of working, resources and funding for a new set of arrangements.
Thank you, Matthew. David, you want to come in on that point?
Just a quick response just to help colleagues. So, and I perhaps should have said it in my introduction as well. So this is slightly out of sync coming to this meeting, but we thought it was valuable for the board to be aware and to sponsor what we're trying to do. With this, we are preparing the content that Matthew's just asked for to go into the system executive group at the end of November, where we'll have a chance to scrutinise that and build out the project and the programme and the detail that's needed. So if it's helpful to board, we can bring it back again. but we did want to wait until after that meeting and then bring it for the first time in January. So that's why it's brought here today. So it's slightly out of sync, Matthew, but hopefully the work is there and it's going on in the background. It will come together at SEG.
And I think you should stick to the timescales that you've set out, David, and let us see it again in January. So I'm going to do a similar thing and ask, is there anybody that doesn't support the plan and the direction of travel at the moment? Okay, so you've got the blessing from the board. It's just to echo the point that you made, David, around the police as partners approach. It's really important and helpful for us that you are working with us to deliver on this, because as Matthew has set out, we have a number of gaps at the moment, and it would be absolutely tragic for our communities if there was just a cliff edge to this. So thank you very much. And I'm going to move us on to David to the next item, which is the Dorset Delivery Plan for Recovery and Access.
Yeah,
thank you very much, Gavin, for joining us.
Yeah. Thanks, Gavin. I don't want to do this a disservice by being quick, but to assure colleagues, it has been through the Primary Care Commissioning Committee, as you'll have seen on the paper a couple of times. And it's brought here because part of the national process, but also as part of our local commitment to practices and populations, we wanted it. Whereas we want to ask the board to approve and to be assured of the work that's underway. So you'll see in the paper that our local communities have benefited from good GP services and access in recent years, and we've started this recovery access programme from a very strong base. But we do recognise that our general practice are under enormous pressure, and so there is great value and importance in this work to support resilience and as part of improving access to our local populations. So you'll see in the paper that most things are either delivered or on track to deliver, and we're doing very well against meeting all the recovering access requirements. I said we have to, this is a kind of national framework and national set of requirements. We are doing this plus, but this is the report about what we're doing in relation to this. So given that it's been through the committees, I wasn't planning to add any further, but we're happy to take any questions or comments.
And David, have you got Rob Payne with you as well? Is he on?
Yeah, I'm here.
He is.
I'm here.
Yeah. Great.
Thanks, Rob.
Okay. Rob, did you want to add anything before we go to questions?
If I may just add a thank you, because I think this is an example of some really good working across the ICB, because this is multifaceted, as you'll see in the paper, and also to our primary care network leaders and other system partners, because this is very much, joint working to progress to the stage we are currently, and then moving forward. As I say, this really is about partnership working. We've got plans in place for primary care networks to be able to support each other as well on sharing the learning and development plans. Thank you.
Thank you. So Jonathan, first question to you.
Yeah, so I suppose, so obviously we've made lots of progress on this, and it's a national initiative and all the rest of it, but there's something, it's all a kind of dissenting voice that it just seems like a wrong-headed approach. We've got more people going to GP than ever before, more people seeing them face to face than before. If you keep encouraging access, they're going to come. They're going to keep coming. If you create a telephone system, if you open up more access, to me the problem is who's accessing, what they're accessing for, and where's that that bit of work saying, well, are the right people using these precious resources, or should we be, where's that task shifting to nurses, where's the task shifting to pharmacies, rather than just playing this government line, which is, well, everyone should be able to see a GP for whatever they want, even if it's actually self-care or something that a pharmacist can do. And I don't know, I mean, obviously we've got to do this, but there's something not quite right or there needs to be a balancing approach, maybe, yeah, of when do we start segmenting the audience, when do we actually say we can't keep on putting more and more people accessing through this because the resources aren't getting any bigger. We've got to actually start shifting some of this and educating. So it's a dissenting voice. I mean, obviously the work is good, it's got to be done, but I don't know, there's something not quite right about this.
I think it's a fairly fundamental question, actually. So David, not that he's asking you to speak on behalf of government, but David and Paul.
That's how difficult it is to bite my tongue about the broader context for this. What I would say is that it does come with funding. So if we want to attract that funding and bring it into our system, we have to hit certain markers, which is what we're doing. And it also is tackling a needs or gap or pressures that we have now. But actually, the solution that will really support this, that will really help this, and do all the things you've just said, Jonathan, is in the work we've just been describing around the integrated neighbourhood teams, because they're built with a sort of primary care access at its core, bringing the assets and the resources of local communities, third sector, local authority, mental health, community nursing, practice nursing, all together to give people alternatives and different options. The route in may be in the future, maybe through primary care contact and then shared out, whatever. It will get there, but that's the bit that's going to fundamentally shift to the way of working you've just described. In the meantime, we have to keep this going, and this is why we've taken the approach we've taken so far, but we're not blind to the broader need.
Okay, thank you. Paul and then Patricia.
So I think adding to that, John, I think there's a couple of points. I think firstly, we've got to recognise that there is a huge amount of unmet need out there at the moment, and particularly if we're looking at some of the long-term disease condition management and identifying of things, particularly around cardiovascular disease, but not just that. Lots of the things that general practice is really well set up to do around managing people with their conditions. There's a big gap there, and we've got to try and support general practice to close that gap so people can get the help when they need to. There will always be a challenge about people using the resources in the most efficient way, and I don't think we've ever managed to significantly change it. We can look at people attending EDs when actually we think they could go somewhere else, but people still attend EDs. But so human behaviour is human behaviour, and what we've got to do, part of the access work, is to make sure that we've got a front door that makes sure that we can get the right people seeing them. And it doesn't necessarily need to be a GP, but often it will be within that general practice setting.
Jonathan, you wanted to come back in before I bring Patricia?
No, I made my point. I mean, I think this is a really broad subject. I think the behaviour thing is the thing we need to look at. It's we can change people's behaviour. It's possible.
It's nudge behaviour therapy.
It's not a technology thing; it's a behaviour thing, and and it's actually that's the sort of thing with the place-based stuff is actually that's a behaviour change exercise as much as anything else. But yeah, I've said enough.
And I know Rhiannon's really keen on that as well. So Patricia.
I'm trying to think about being careful what I say, because every time I speak in this public board, I end up on front page of the Health Service Journal.
Remember that we are meeting in public, so
this is part of NHS that really frustrates me. I think one, because we measure all the wrong things, and so I think we need to get smarter at not just doing things because it comes with funding actually, and having a conversation back to NHS England that says we still want the funding, but we want to do something different because it's the right thing to do. Because the reality is we can, while we're having this conversation nationally about improving access to GPs, we haven't got enough GPs nationally. So what we're doing is putting more pressure on primary care, and that's not good either, because it's just leading to higher rates of attrition. So I think I'm sort of with Jonathan in that there's something about having, I think we haven't managed to change the bell curve on the demand for the NHS. One, because there's a lot of response to want as opposed to need, and that's the whole point of ICSs and the 4 purposes, is to change that. But also, we're not having an honest conversation with the public about what they need in terms of response, and then how do we shape the urgent and emergency service to deal with that. And until we do that, we're always going to find primary care under extraordinary amounts of pressure. So I think we need to think very differently about how we engage with NHS England when we're asked to do these type of things that we know are not necessarily the right response to the problem, and how we work alongside them and our communities to craft the right response. Because I do get really frustrated about us ticking the box and missing the point sometimes.
Yeah.
So Patricia, I cut out my internet cut out right at the beginning. It's probably on purpose, but let's hope you didn't say anything that we wouldn't want said. I wonder, on the back of what you've said, whether or not there is an opportunity for us to kind of go back to NHS England and reshape so that it's a primary care access as opposed to GP. Because I think you're right. You know, picking up on the point that Jonathan's made, we have got the experience on the ground, and we should be using that to try and influence around how some of this is happening. So David, I don't know if you feel able to do that. Rachel, you want to come in? Go on.
Well, I suppose you'd expect me to respond by saying in the Southwest, and David will know this, we do appreciate it is wider primary care. It's never been just about GP access, because as Patricia rightly says, we don't have, we're losing GP, certainly losing significant partners, and we don't have the pipeline of new GPs coming forward. So I think you're right, strategically and from a sustainability perspective, it has to be about wider primary care, and that's where it links to your integrated neighbourhood team. So we do understand that, and that's certainly the approach that I would be encouraging the Southwest to take, and I know they will be taking.
Great, thank you. So again, it's here for approval, is it? Is it what do you need from us, David, in relation to this?
So it's a part of the requirement. So having just said everything we said about, you know, do it our own way, part of the expectation and requirement nationally for this programme is that the board assures itself that this programme has been adopted and the plans are in place to deliver it. So the board we're seeking your assurance for that.
Yeah. And then you've heard the broader comments around let's make this work, and I think we've got Rachel's lesson on that. So thank you very much, and thank you, Rob, for joining us. Let's move on then to Dean and the ICB annual assessment outcome.
Thank you. I'll just do a short introduction given time. These are, you'll remember we've done an annual assessment process with NHS England, and these are the responses back. Kind of a longer one with lots of detail in, and a shorter one with kind of a summary of that. I think what we've done is we have gone through that report and looked at where the gaps are, and kind of assured ourselves that we have got all of the work is in train to cover the gaps that was identified in the report.
Okay, that was brief. Thank you. You took me by surprise there. Okay, so are there any questions or comments? Patricia and Rachel, I don't know if they're legacy hands or are they up for here?
On the legacy.
Okay.
Yeah.
So any questions? Thank you. Any questions or comments for Dean? Okay, thank you very much then. So that takes us through all the items that we had for noting and discussion. So we're now going to move on to items for consent. Normally what we would do here is answer. I'll put your hand down, Rachel, because I think you're struggling to get it down.
Apologies, Chair. I can't actually see it or put it down.
No,
so
don't
yes,
worry.
thank you.
I've put it down for you, so it's fine. What we'd normally do here is to take questions from the public. But as I said at the beginning, those questions are submitted in advance. We haven't had any submitted in advance on this occasion, so we haven't got any questions to cover. So what I'd like to do before we move on to key messages and reviewing the meeting is just to check if there is any other business. Can I start with the room? And you can try waving at me. It's a really small screen. So if I start with Cecilia and then work our way round.
No. No.
John?
No.
I don't know who's sitting next to John. Oh, it's Kay.
No. No.
Who's next? Okay.
No.
Patricia?
No.
No. Coming up the other way, it's Liz, then who's next to Liz? Okay. And Rob? Is that a no?
A no from me, and it's a no from Stephen. Yeah.
Okay, I can't see Stephen. Thank you. And then if I go around the screen then, so Zoe?
No.
Jim?
No.
Graham and Vicky?
No, we're good, thanks.
Thank you. Spencer?
No, nothing from me, thanks.
Thank you, John.
No, thank you.
Dawn. Sorry, I already covered you in the room, didn't I, Dawn and Patricia? Dan?
No, thanks.
Neil?
No.
Paul?
No.
Rhiannon?
Nothing, thanks.
Debbie?
No, thank you.
Dean?
No, thanks.
David? You're saying something, but you're on mute.
I am sorry, I just realised. So I've got a comment, and I don't know if it fits here or whether we've got time for the next item around reflections on the meeting. Are we going to cover that one next? Are we going to be able to? Have we got time to fit that in? If not, I'll squeeze it in here.
Sorry, David, you cut out. My system cut out, so I didn't hear what you said.
Jenny, I was asking if we got time for the reflections on the meeting section next, because I know sometimes we carry that forward.
We are going to do that next. No, we're
okay,
going to do that
I'll
next.
save it. I'll save it for them.
Yeah.
Thank you.
Okay. And then I think it was just Neil that I didn't get to. Is Neil gone? He's dropped off my screen.
He's gone.
Okay. Yeah, maybe he's gone. Rachel, did you have anything?
No, thanks.
Great. Okay, so then let's do the key messages and review of part 1. Liz, have you captured key messages as we've been going?
Yeah. Did you want me to?
Please, if you could.
4 key messages. One was our commitment to and support for freedom to speak up mechanisms across the system to support a culture of psychological safety and learning. Second was around the challenges relating to performance in the NHS financial position, especially noting the impact of industrial action and the resulting impact on quality and safety. The third was our commitment to the approaches for the 3 items, which were integrated neighbourhood teams, work, health inequalities, and right care, right person. And the fourth was that we had received assurance on the Dorset Delivery Plan for Recovering Access, noting the collaborative work across the system which had contributed to this.
Great. Does that capture everything for everyone? Is there anything that we've not mentioned? Okay, let's. You're looking quizzical, Debbie. Have we missed something?
No, I was actually thinking. That was my thinking, okay. Right. I think we've captured everything.
So apologies. Okay, so then let's review the meeting. David, did you want to start?
I don't mind starting. So I was just, I was kind of, I have a curiosity, I suppose, which is about how people are arriving into our conversations that we're having. Around our intent, around the way that we want to work with our communities and partners and VCS and all the way up. Some of the discussion items have been, there's been challenge, I guess, on the way this is the NHS, this is the NHS, this is the way the NHS is doing it. But actually a lot of the things we've got on our agenda today, and Liz summarised it really well, around the integrated neighbourhood teams, the health inequalities, the way we're working with right care, right person, even the access to GP services is a broad spectrum of partnerships coming together. And although this is the NHS Dorset Integrated Care Board, it is here as a unitary authority whereby we are assuring ourselves and checking ourselves and challenging ourselves to make sure that we're covering the broad spectrum and not just health. It includes NHS, but it's not just about NHS. And what I've heard through the conversation today is quite a bit of challenge that this is a bit NHS centric. We challenged ourselves on it, but we've heard that challenge from partners as well. And I'm interested as to why people might think that this is only about the NHS and whether there's something we're not getting right in the structure and the nature of the conversations that we're having across the agenda that makes it feel too NHS centric. So it is important for us and the work that we do that we are seen as partners amongst partners. This is not just about the NHS. Does that make sense?
I think it's a really useful question. Actually, I was going to ask a question about something else. So let's dwell on that for a moment. Rhiannon.
Yeah, just to David's point, actually, for me personally, this has been a much more balanced feel in terms of that wider perspective, and I've really welcomed that. I wished we'd had a bit more time on the inequalities bit, actually, because that's, you know, that's a fundamental element that we as an ICB, and that's not a criticism to take it that way, because I know that it's always about managing time. So actually, for me personally, it's been a much more balanced meeting this time. I mean, I wasn't at the last one, and I know I'm still early doors in terms of, you know, my time with Dorset, but I've really welcomed those wider things today.
I think that's right, but I think David is correct also, though, that because there have been comments throughout the meeting that it's focused on health. So, Paul.
So I guess it's just building on Rhiannon's point, and it's so I guess we had plenty of time for some discussions and no time for others, and I guess my challenge is if health inequalities is really important, either we got the paper wrong, or we didn't have time, or it's not as important as we say it is. I do feel for the people who put a lot of work in the papers and come along and they're gone within 5 minutes. I think it's quite tough on our teams when they experience that. So I guess I guess we've got to make sure when we look through the agenda that we are honest with ourselves about the bits that are important, and to make sure we give them the airtime that they need and the conversations that they need.
Yes, Patricia.
So I think we need to think a bit more carefully when we're planning the agenda, because today we've had some important things on the agenda and it's felt a bit rushed. So we need to think a bit more carefully about the items that we really do want to get into some depth of discussion on, and the ones that we basically can take on the nod without a lot of comment or question. And I think that's not just about planning the agenda, but it's also about us as a board being disciplined as well. Because we said before that if we're going to speak and just agree with the previous person, can we not, and just put plus one in the chat box? And we're still not quite getting to that place either. I think the agenda's been quite broad this time, and we do try hard to put things on the agenda that are not just about our ICB assurance piece, but are about the wider system. But I do recognise there's been some comments today, and I think some of that is because we need to get better at articulating some of the work that is going on, and the fact that we might be into, like, the integrated neighbourhood team is a great example. What we're doing now is stage one, but actually stage two is about bringing in other partners and moving that away from just elderly people into the whole community. I do want colleagues to recognise, though, that health isn't going to solve everything, and it sort of gets back to Matthew's point earlier on about perfection can be the challenge to good, and we're never going to get to perfection. We're not going to solve the cost of living crisis, but what we can do is provide out of hospital care that at least starts to tackle the equity question, and then bring other partners into that forum to start to think about how some of those broader issues are addressed through social prescribing and care coordinators. So I think we've got to get better at articulating the phases of work that are ongoing that get us into that sort of broader space, rather than it just being health focused. But I don't want us to forget that one of the principal focuses or responsibilities of the ICB as a statutory board is to make sure that the ICB is fulfilling its statutory functions under law, and that still has to be a significant part of our conversation because it's the purpose of the board.
Yeah. John, you had your hand up, you've put it down. You might be doing what Patricia suggested, which is plus one.
I just put plus one in the chat.
I thought that might be the case. So I mean, in terms of the flow of the meeting, I've got to take responsibility for that, because we were significantly behind time. And when I looked at the timing of the substantive papers, I mean, they were here for noting, but nonetheless they were substantive items. It did not seem possible to do that within 15 minutes. So I think there is something that we need to do around the timing of those big agenda items, because actually the introduction of those items took almost the full time, which meant that we just didn't have the time then for in-depth discussion. So we'll do some more thinking about that when we're planning the agenda items.
Jenny.
Sorry.
Sorry.
Yes.
You didn't see me wave. It's Rob.
Oh, sorry, Rob. I didn't see you waving. Apologies.
So I'm slightly guilty because I think I might have started that conversation in the finance report, and I said apologies because we've been trying to broaden it out. To Patricia's point, yes, it is about the ICB position and our NHS control total. We have to do that, and we did. But for me, the bit that I'm wrestling with is the fact that local authority financial positions and the NHS financial positions are kept separate by government, but for our residents, they're one and the same thing, aren't they? And as we get into the transformation and the integrated neighbourhood teams, we're talking about PHC and we're also talking about adult social care. All of these things are so interconnected that actually that's the bit. So that I think there is a requirement as we develop, as we mature, that we somehow make those links through. So I'm thinking within the finance world, how do I manage to link some of these great conversations we've had which are wider, so that we can start understanding what that truly means? Because it's no good if a local authority is going to be bankrupt and then the NHS is bankrupt and we're all bankrupt, and actually we could have helped ourselves a bit. It'd be better to be a bit less bankrupt, wouldn't it? Or we could all be in balance and doing really well. So I think our medium plan, we've got to get that sort of knitting across bit more, I think. So yes, we have our statutory duty, we can do that. That's the easy bit in terms of reporting to the board. But it's the other bits that I think are really important that we start developing.
Yeah, and I think, Rob, that links to the point that I wanted to raise, which is around how do we flag in the papers the connectivity? Because I think that's some of the issue that's come up today about, you know, some of this feels like silos, and when people have responded, they're clearly not, but we're not able to tease it out of the paper. So I wonder if there's something about just spending a bit of time on the cover, really thinking about how it links to the various things that we have on the agenda and the various programs that we're having, because I think that might then help us to frame some of the questions and comments that we're putting in. But some really good stuff that came through today, and opening the work that we're meant to do. Who wants to come in? Somebody in the room, I think. Oh, I heard somebody talking. Okay. Any more comments then? Because if not, I will note that the next meeting is going to be on the 11th of January. Can you believe it? This is probably my time to say Merry Christmas and Happy New Year, isn't it? Gosh, that's scary. So 11th of January 2024 is the next board meeting. And then that just leaves me to bring this session of the meeting in public to a close. Thank you to all members of the public that joined us today. We are now going to break for lunch.